6, and it is 4:03 p.m. As the quorum of the committee is in attendance, I would like to call to order the meeting of the Central Health Budget and Finance Committee. As a reminder, some of our committee members, do we have any committee members online this evening? So there will, okay, if anyone shows up, please let us know. So we will be, staff will be managing video and audio feeds of all times. Now, we are gonna move on to public communication. I would like to announce that in order to make it more accessible to community members, I am gonna actually take public communication now. Is that fine, Chair? Do we have anyone signed up for 5:30 p.m.?
Yes, we have 5 people signed up
For 5:30 or for right now?
for right now for 4 p.m.
Okay, perfect. So let's move forward with taking public communication. And,
Okay.
Yesena, if you can move forward with that item, thank you.
Yes, thank you. While I read off the guidelines, could I please have Miss Rachel Blair come up to the microphone, and I'll call Ryan Poppy, who is online. So please introduce yourselves by name before beginning your comments. If your comments will focus on a specific item or issue on the agenda, please indicate the full item number after your introduction. Each speaker will be limited to 3 minutes. Staff will be timing each speaker and will announce when a speaker has reached their limit. Once we have let speakers know they've reached their limit, we'll allow 30 more seconds to wrap up their comments. Due to the restrictions of the Open Meetings Act, the board may be restricted in discussing any items that are not listed on the agenda for this meeting. The board may choose to set aside any new issues for discussion at a future meeting. So first up, I have Ryan Poppy, who is online with United Workers of Integral Care. Thank you, Ryan. You have 3 minutes.
Thank you. Good afternoon, Chair and members of the board. My name is Ryan Poppy, and I am with CWA Local 6154 and the United Workers of Integral Care, the people who turn the investments that you guys make on this dais into actual services for our community. I want to commend Central Health for recognizing the importance of behavioral health and its investment in integral care. But something that can get lost when we talk about budgets in terms of contracts, programs, and dollar amounts, the money doesn't deliver the care. People do. And integral care workers are answering calls, responding to crisis, sitting with people in their darkest moments. If we want these investments to succeed, we have to invest in the people doing the work. That's why I'm asking the board to strongly support a 4% cost of living adjustment for integral care employees. And I want to make an important distinction. When the city of Austin or Travis County or even Central Health approves a salary increase for their employees, that does not automatically mean integral care employees receive the same increase. Those dollars still have to make their way through Integral Care's budget and compensation decisions. But this board has significant influence, and I respectfully ask you to use it to make workforce investment part of the conversation with Integral Care leadership. I also want to raise paid parental leave. Integral care workers should not have to choose between welcoming a new child and maintaining their financial stability. I recognize that employment policies are ultimately the responsibility of integral care executives, but Central Health is a major partner and funder, and I encourage this board to use that partnership to open a constructive conversation about establishing meaningful paid parental leave. This is about retention, it's about recruitment, and ultimately, it's about continuity of care. Central Health has made a tremendous difference, not only by funding services, but by helping ensure that the workforce delivering those services can afford to stay. Invest in the workers, protect the workforce, and give people delivering behavioral health care the support they deserve. Thank you.
Thank you.
Thank you, Ryan. Up next, we have Rachel Blair with Health Alliance for Austin Musicians. And if you press the button in front of you, Rachel, the light should turn red.
That one? We're good?
Yes.
Okay.
Thank you.
Good evening. Thank you so much for having me this evening. My name's Rachel Blair. I'm the Chief Strategy Officer for the Health Alliance for Austin Musicians. I wanted to start by thanking all of the Board of Managers and also the staff who have been working tirelessly preparing the budget and have been working really constructively with us. I'm here to speak on the budget this evening. As a quick refresh, HAM, Central Health, and Sendero have a partnership to allocate premium assistance dollars to help small business owners and gig workers become fully insured under the Affordable Care Act. Right now, HAM has more than 1,400 members that meet criteria for this program, 75% of which roughly are enrolled. We are projecting that another 350 folks could be enrolled on top of our existing numbers during this fall's open enrollment. Many of these individuals joined because our outreach succeeded and Central Health funded pre and post enrollment work and has prepared them for coverage. Their presence on our waiting list shows that our outreach pipeline is working and that we are reaching more musicians of color, more female identifying musicians than we ever have before. Rising premiums, the end of the enhanced tax credits, federal tax credits, and the loss of the special enrollment period for those individuals making less than 150% FPL has increased the need and narrowed the opportunity for enrollment, making this fall's open enrollment period a high pressure environment to get as many people enrolled as possible. Earlier this month, our partnership made national news. We were, Central Health, Sendero, and HAM, we were all featured on NPR's All Things Considered, reaching millions of people across the country. It highlighted nationally what we've built together over 10 plus years, durable community health infrastructure. Together, we provide public stewardship, locally rooted insurance, and trusted community implementation. The long-term question for us is whether or not this investment preserves capabilities that produce and maintain public value. It does. This infrastructure brings federal premium tax dollars into Travis County, supports provider reimbursement, and reduces pressure on the local funded safety net system. It insulates all of us from instability in the highly volatile environments of community healthcare, insurance, and gig-based workers trying to make ends meet. As you finalize the FY27 budget, I respectfully ask that you maintain the allocation for HAM's Premium Assistance Program, Central Health's Premium Assistance Program with Sendero. That will allow us to enroll waiting members from priority populations and preserve an essential part of the durable infrastructure that we've built together. Thank you for your continued investment in the long game of community health coverage.
Thank you, Rachel. Up next, we have Mr. Larry Wallace, Sr.
Good afternoon. My name's Larry Wallace, Senior, and I'm with the Black Men's Health Clinic. And I'm just here to take my 3 minutes to offer a praise report to this board and its organization. A praise report at church is when something good happens and we acknowledge it and we give thanks. We don't take for granted your support. We are approaching 5 years of being in operation, and we could not do it without you. I also want to acknowledge our partner, Community Care. We have a very unique aligned relationship. We bring men of color into care who normally would not come for a number of reasons. And Community Care, along with, we have a fabulous provider, Dr. Jenkins. I must acknowledge him. He treats our men with respect and dignity, and he walks the talk that we promise. When we tell men, come into our space, you'll be treated with dignity and respect. You'll have an experience you never had before. And earlier today in a meeting, Dr. Lee. We talked about, somebody mentioned stories. I have so many stories of men who have come through our service, and at the end, they have hearts of gratitude because what they tell us is we saved their lives. And as we lift up men, we lift up families. And so the work we do is important, and we couldn't do it without you. Just like what you heard the previous speaker, we've had national recognition for what we do. And every time we are acknowledged, we make sure people know that we have partners that support us, Central Health and Community Care. And without these partners, we would not be who we are and what we are. So I'm just here to say thank you. Thank you for support, and we're coming up on 5 years. The reputation in the community is strong. I love it when I go places and when people know I'm from Black Men's Health Clinic. I never hear a complaint. I never hear a negative word about our provider and the services. And it's good to know that when you have a vision and when that vision is executed and you get the result that you want. And so we know we're making a difference. We could line men up out here and they can come and tell their story, but we won't do that for the sake of time. So I represent all those men, all those people who would not be in care, who would not have received services, and to say thank you on behalf of all of them. So thank you again.
Thank you, Mr. Wallace Sr. Up next, we have Mr. Shannon Jones.
Good afternoon. I don't have time to read all of this, so you don't have to worry about that. But I did want to talk briefly about what this is. Each of these are data reports that have been generated by Central Health, Austin Public Health, or University of Texas, or other agencies about the health status of our community. They all say one thing, that the population, primarily that of color, and primarily that's east of 35, is disproportionately impacted. This is Community Care's report, City of Austin's report, another City of Austin report. Here's a report that goes back to 2012, one that goes to 2015. Now, many of you may not be interested in this, but the people who are indeed impacted by this are. And they're dying a disproportionate number, and the data clearly says that. City of Austin, as well as Central Health, has put out several reports talking about the health status of those populations. Now, the question is, we are concerned about whether or not we're working in those populations, targeted populations. We don't have to refer to the populations as targeted population. Your role is to do 200% of poverty and below. So it's important that you make sure that your service contractors with agencies like Black Men's Health Clinic, C2H, the Latino Health Care Forum, many of those organizations that focus in on these populations are served, despite what the federal and state government are saying. If you don't want to call the population by their race or their ethnicity, then just call them by the disparate population. If you, not you, but if the community doesn't want to do that, then let's be mindful that these are the population that we pay taxes for. And so if we're going to make a difference, call them what you wish. These are the population of our service. So it's important to make sure that as you look at your budget this year and the future years, that you put funding in that area. Otherwise, the 200% of poverty focus is nothing but conversation. And I think that's absolutely horrendous. In closing, I'd like to say, having been on the board for many years, that was one of my commitments, is to address the population. I hope and I'm seeing that you all are still interested in doing that. But your failure to do that will be reflected in terms of the outcomes. And whether it's me or someone else coming up here later saying that the Central Health has failed to meet its need, it will depend upon what the data says, not what people pontificate on, what the
30
data
seconds.
says. So please be mindful that there's data that support what you're doing and evaluate it in terms of your recommendation for funding for the future. Thank you very much.
Thank you, Mr. Jones. Up next, we have Summer Lee and Adriana Garcia. And Summer and Adriana are going to share the 3 minutes, and the microphone is on, so y'all don't need to press anything. Thank you.
Thank you all for having us here today. My name is Summer Lee. I'm a workforce advocate here, and I sit on the people team. I manage our Workforce Advocacy Council.
Hola, mi nombre es Adriana García y trabajo como especialista de coordinación de servicios de salud en el Centro de Navegación y presido el Consejo de Defensa de la Fuerza Laboral.
Today, we're here to share some important information about an upcoming event. September 15th to October 15th marks Hispanic Heritage Month. To celebrate, the Workforce Advocacy Council will be hosting a system-wide team member event. On Thursday, September 10th, the council will be highlighting the team behind Vivir con Ganas through a panel discussion. This event has been carefully crafted to be held after clinic hours so that all team members can enjoy the opportunity to connect and network. Additionally, we have opened this event to the public.
Hoy estamos aquí para compartir con ustedes importante información sobre nuestro próximo evento. El 15 de septiembre al 15 de octubre se celebra el mes de herencia hispana y el 10 de septiembre jueves el consejo destacará al equipo detrás de Vivir con Ganas mediante un panel de discusión. Este evento se ha programado para después del horario de atención de las clínicas con el fin de que todos los empleados podrán asistir al evento y también hemos abierto este evento al público para fomentar aún más la participación. Nos encantaría contar con la presencia de nuestra junta directiva y equipo liderazgo como representación visible de compromiso de los miembros del equipo, alineándose nuestro objetivo de aumentar aún más la satisfacción de los miembros de la organización.
We would love to see our board and leadership team in attendance to be a visible representation for team member engagement. This event directly supports our goal of increasing team member satisfaction and belonging. We hope you all will join us in making this a meaningful experience for our workforce. Leaders, we encourage you to continue sharing the event information with your teams, as our goal is to reach and welcome 200 team members across the system to the event. Thank you for your time and support.
Thank you.
Thank y'all. And this concludes this evening's public comment.
Okay, thank you. Is there anyone here that would like to make any comments that we have not called on? Okay, I don't see anyone, so thank you all for your comments. Moving on to our agenda. So, moving on to agenda number 1, approve the minutes of the July 29th, 2026 Budget and Finance Committee meeting. Do I have a motion?
So moved.
So I have a motion by Chair May and a second by Dr. Martin. Any comments? I see none. All in favor?
Aye.
Motion passes unanimously. Thank you. Members, for item 2 and 3, which is 2 is receive the July 2026 financial statements for Central Health, and item number 3, receive the July 2026 financial statements for Community Care Health Centers. We do not have a presentation for those 2 items, and there is some information in the backup board materials for your reference. And there wasn't anything outstanding for them to come and report. So we, in favor of time, we opted with no presentation. So As you all know, we have a very heavy and jammed agenda, so we are hoping that we can move forward as concisely as possible and have a fruitful conversation and discussion on all our topics today. And with that, I just wanted to acquaint you that for item number 6, just that we will be going into closed session for a few minutes for attorney-client opinion, and then we'll come back in open for that presentation, and then we will go back again in closed for items number 7 and 8, I believe. Okay, that's, yes. Do you have?
Yeah, I just have a question. Item 8 is the, I
Item
think
8
I'm
is
looking at the,
Sendero.
I'm sorry, I'm looking at it the wrong number. Okay, never mind.
Yes, and item 7, we have community care.
Yeah, that's fine. I was looking at the wrong number.
Okay, no, I just, yes. So I just wanted to acquaint everyone here how we're going to be proceeding. Okay, so moving on to item number 4, discuss the appropriate action on fiscal year 2027 Central Health Foundation budget. Virginia Potter and Michael Wiggins will be presenting. So members, I just want to kind of acquaint you with this item. Central Health Board voted for a foundation, so we have that in place, so it has been filed. Now, we want to enable them to move forward with this foundation. By no means is Central Health Board going to be overseeing their long-term budget and their operations. That's up to their board, their future board. But what we're positioned here today is to really enable them with startup fees that will be in our budget and to discuss how they can move forward. So I just wanted to make that clarification to the public and to our members, the essence of this item. So Virginia, if you can, you and Michael present, and I know we're just, hopefully if you can make it very short to the point, and then we can have a discussion with our board members. Thank you.
You got it. Thank you, Dr. Masaitif, for that wonderful table setting. Thank you all for allowing us to be here today. We will keep it to the point. All right, so if we go to our first slide, what you'll see first, everyone, is the summary of the startup costs for the foundation. And we carefully and thoughtfully crafted these, making sure that we're grounded in exactly what we need. And we wanted to take a little bit of time today to show you what we're asking for and exactly how we'll use these funds. The first piece that you'll see is the salary piece. And they're $388,300 there. These are net new salaries. So this is 2.5 new hires and specifically focused on development. So you'll see there's a major gifts officer there. There's someone who would manage annual campaign and stewardship, and some administrative support. But this is really key because these are skills that we don't currently have access to. So this will get us off and running and really advance our fundraising. Next up, our fundraising activities. Just over $154,000. That will include our launch event, launch marketing materials, and things of that nature. Next up, we have infrastructure and our professional services at $370,000. The bulk of those costs is to ensure we have the right customer relationship management tools to manage our relationships with our donors. We are getting our nonprofit discount for that, so we've been working internally with our partners across all the finance and legal and tech teams to ensure we're making the right choices there. And so that total you'll see at the bottom is the number $912,800 that you saw in the budget memo a few weeks back. So we're just giving you a little bit more additional detail so you can know where we are. So if we move on to our next slide, we know that the question of potential investment reimbursement in the foundation has been a topic since we were in the days of approving the legal entity to go forward. So we wanted to come back to you on that and let you know what we've been thinking. We want to honor the direction or the interest in this area from you all, but also be smart about what's realistic in a first-year foundation. So our commitment to you is that we are going to be very diligent in collecting all of the cost data. So not only the startup costs that you saw on the previous slide, but also the cost of that where we've been getting support from Central Health staff to make sure that we're doing everything we can to both be lean, but also be smart about what's exactly needed to make us successful. So we will be collecting that data. We will make sure that we're being mindful of the resources we're raising. So in order for us to be able to use funds to repay back in a reimbursement situation, we have to make sure those are flexible and unrestricted. And so we're trying to balance being able to offer resources back, but also being mindful of how do we maintain donor trust so they know exactly what, when they give us funds to use, they know what it's going for. And then, of course, along the way, we are partnering with finance. They have been incredible partners to us in thinking about how do we approach this, how do we keep track and monitor along the way. And as always, we will be coming back to you and seeking direction and really striking that balance between being good stewards of our taxpayer resources and also maintaining donor trust along the way. So we're really excited to be able to do this and appreciate your interest in this area with us. And so our last slide is really just a summary back to the beginning. So just really three major categories of startup. And again, we're really trying to make sure that we are balancing the opportunity to move forward with the right fundraising capacity, but really be lean about what's truly needed just for the startup cost in this first year. And we welcome any questions you have.
Thank you both for your leadership on this. Appreciate it. I will take a motion from the vice chair and then we'll open it to questions.
You want to take questions first?
Let's have a motion on the table. Can you?
Yeah, I'm happy to make the motion. So the motion that I proposed is per the foundation's legal formation documents approved May 2026, I move that the Budget and Finance Committee recommend that the board approve the proposed Central Health Foundation fiscal year 2027 startup operating budget.
Do I have a second? Okay, so I have a motion by Vice Chair May and a second by Dr. Brinson. Any questions? So, Manager Kitchen.
Well, I have a governance-related question.
Sure.
First off, I don't have objections to the budget. Let me just be clear about that. It makes sense, and it sounds to me like the goal is ultimately to be paid back. But I really have a process question. So I think I need to understand what we're doing with this motion. Because I don't think it's timely to approve it, but I'm not quite sure what you meant by the motion, so I'll have to ask you that. I don't think it's timely to approve the budget of one of our entities that we work with before we approve the budget for the entire system. So I would be more comfortable just approving a dollar amount that is startup cost, but not call it the budget, because we're not at that stage. I mean, it's just like I wouldn't approve the budget of Sendero or CUC right now, because those are all integral pieces of our Central Health system budget. So that's really my governance question, and so that's what I'm trying to understand here. So it may be a matter of how we style it. I can't vote on the budget for right now. I'd have to abstain. So.
Okay, understood. Thank you for that. I just want to bring it to everyone's attention that this foundation does not have a board yet. And
But
just
okay.
just wanted to bring that, distinguish the difference between those two entities that you pointed out.
But that's not my point. It's not my point that I'm waiting for a board. It's my point that it'd be the same way if this was just a department of our system, because we're not approving our budget piecemeal. We approve our budget as a whole. So if we want to, if we feel like we need to approve this right now because they need to act on it before September when we approve the budget, okay, if we need to act on it immediately, I'm okay with that. But I don't want to style it as approval of their budget or of a piece of our budget. Because I could say that there's several pieces of our budget right now that I'd like to go ahead and approve, but that's not the whole budget.
Okay, well, thank you for that. Manager Jefferson?
I really appreciate the comment that Manager Kitchen made, and I would see this more as sort of like, what do you call it, napkin kind of tabulations that are going on. That would be something that we are putting in the budget overall. I personally would rather wait for the foundation board to be in place to follow whatever budget process that's going to be governing their process. So I would be more in favor of us modifying the motion for this to be the allocation in the budget
Do you
for
want this?
foundation.
Yeah.
Motion to read it?
Well, if I can just say, I would just, yeah, can I see your motion? Sure.
Yeah, and then we can.
President.
Manager may move for the approval of the foundation's budget, and my amendment is to make it the approval of the funding amount for the foundation, not its budget per se, in the Central Health FY27 proposed budget.
Okay,
I would
so they,
second that.
I just want to ask the motion, are
Okay.
you,
I've got a motion on the table, so
Go
I've
ahead.
got to accept it or
yeah,
not.
do you accept
yeah.
that
Yeah.
amendment?
I would like discussion on that motion, on the amendment.
Okay, let's have, do we need a second for that, right?
I'll second it.
Okay, a discussion on the table. So, yes,
That makes sense to me, because that's what we're doing. Essentially, we're saying that this is the amount of dollars. We're expressing our interest in startup funding, and we're expressing the amount that we think is appropriate, and we're expressing the amount that we would like to see in our budget, but we are not approving an operating budget for the foundation at this point in time.
okay. And let me just,
Yeah, let your honor move first.
oh, you don't, okay, because you had your light on.
Oh, sorry, Dr. Maher.
Yeah, that's why I just wanted to make sure.
Yeah, just a point of clarification. And I don't know if this is probably to the lawyers here. If we accept if Manager May accepts the motion, the amendment, would this allow them to move forward with whatever it is that they need to do with the work that they're doing? In other words, like, is what we're doing just like a statement, or does it allow the administration to move forward with their startup costs? Does that make sense? Like, just an operational?
Can I ask a question, or, I don't know.
Yeah, go ahead.
Is if the, well, I don't know what your intent was, but to me, the intent is, you know, we're saying you can go ahead and proceed with hiring because we're gonna back you up with these dollars, for example. That's what it means to me.
That wasn't
that's what I
my
was trying.
intention.
Okay, that wasn't your, okay, I'm sorry.
No, I kind of would like the foundation board to have some kind of say in all of it myself. So that was my intention. That was just
Okay.
putting the money in place for that to happen, but not to present it to them with a bow and say, here it is. So that was my intention.
Okay, Dr. Martin?
Yeah, I hear what y'all are both saying. To me, it seems that we're kind of splitting hairs about this. I think that they're essentially saying is that this is what we will be putting in our budget, that we essentially approve this amount that then we vote on. But I would favor giving them the green light to move ahead with understanding that this will be part of the budget that's presented to the entire board as a separate entity, but just for expediency we can agree essentially on the data they've given us. That's how I see it. Thank you.
Thank you for
I
that.
did have one question for y'all.
Yes,
And I'm sure you
Kristen.
did it. But how much did you research other foundation models to come to these roles and salaries, et cetera?
Yeah, it's a great question. As part of the work over the last 12 months, when we were researching our peer districts across the state, and even to some degree across the nation, we were benchmarking the teams, seeing who they actually were hiring. When they thought of their development team, some of their teams are very large. Where did they start? So we did have many conversations with peer districts across the state, and we also talked to a few other taxing district entities like Austin Community College Foundation to see how they were approaching it, since they're having a refresh of their work as well. So we do have that documentation, and it was kind of the highlights of Harris Health, Parkland, JPS, and Fort Worth.
Thank you very much.
Thank you.
Dr. Martin. Chair May, I think she had a clarifying question.
Oh, well, I was gonna ask a question of the staff with respect to your amendment.
Yes, if we can do that.
May I do that?
Can I just speak to my amendment?
Yeah, go ahead.
Hearing from a number of you, it doesn't seem like there's enough support for what I would prefer to have, so I'm happy to just withdraw, because my motion is not to just go ahead and present it with a vote. Whatever is done in terms of getting a CRM system and all of that, I don't know if if that requires the approval of their budget. So
Let me, if I may speak
Yes,
to
ma'am.
this. I think the intent of them presenting their budget is so that they can feel like they're moving along, they're moving this process along with respect to the creation of the foundation. And obviously, there are certain pieces that need to be in place. A budget is first and foremost of any creation of any nonprofit. If you don't have a vision for how you're gonna spend money, how do you have the vision, how you're gonna raise it? So, I mean, that is essential to the matter. Now, in terms of where, the work that they've done, I know the screen's off, but in terms of where the money's gonna go, I think that they've done to this, at least to this point, their due diligence in doing the best they could with establishing the research they needed in order to make sure that the components that they need for the startup are in place. I think us approving their budget today is gonna do several things for us. Number one, it gives them the clear go-ahead to keep moving as they have been moving, as we have already authorized through the formation documents. And that way they have the confidence to do that. Number two, it also enables them to start being in a place where they can start receiving money, because there's money, they're already working on grants and stuff, and some of them have already been. Recently, Virginia, didn't you tell me you had a big win with the Moody Foundation?
We have, in partnership with Community Care, they're supporting women's and children's health at Community Care, the Moody Foundation, and they're excited to continue to work with all of our entities.
So, again, my feeling is if we can put them in place, so that way as they're moving forward with their asks, there's something there, there's a real operation there that is supporting the ask. And I think that's important for purposes of our ability to continue to grow the foundation. So I would ask us to support it as we've submitted it. The motion was made, happy to read it again.
We have an amendment, so I don't know if she wants to withdraw it before we can discuss.
She did, didn't you?
with permission, I'd like to withdraw it. I think Manager Kitchen probably
I have
has her own
another
motion.
amendment.
Okay, so you're gonna withdraw, okay.
I have an amendment to make.
Do we have to accept that?
You have to let me make my amendment.
Okay, go ahead, make your amendment. I'm sorry, there's multiple things on the floor. Okay, please proceed.
Okay.
Manager Kitchen.
Well, first I have a question and then I have some
Yeah.
language. So, are you guys needing to spend money before September? On these costs?
No, we're actively being prepared so at the turn of the new fiscal year,
Okay.
should these funds be approved as part of the new overarching budget,
Okay.
that's when we could start spending funds.
Okay, so you need to fund starting the new fiscal year.
Yes, but I guess one of the key pieces is, could we actually start recruiting for those roles that we know that
Okay,
will take us some time? So that's
Yeah.
maybe a nuance where our heads are, because we know that'll take, potentially 6+ months or more.
Okay.
Yeah.
All right, that answered my question.
Okay.
So that informs the motion I want to make, because if I'm hearing you correctly, these funds will come out of our next year's budget, not the current budget. So, okay, here's my proposed amendment. Per the foundation's legal formation documents, I move that the Budget and Finance Committee recommend that the board approve the proposed Central Health Foundation fiscal year 2027 startup operating cost as part of the Central Health budget. Cost to be included in our Central Health budget, and that we authorize the foundations to begin recruiting for the roles that are mentioned in the budget.
I'm not gonna
The
accept
motion
it.
maker, do you accept them?
No, I'm not gonna accept it, and let me explain why I'm not gonna accept it. I'm not gonna accept it because I'd like to see this foundation start off as fast as it can go. And as we are beginning to move the foundation, every piece, every decision we make is one step closer to us having a solid foundation on the ground. And it's really critically important because, as you all know, we've got some other major items down the road on today's conversation about our dollars that I want to make sure that those things are in place.
Okay, so let me just explain my reasoning. We do not have the authority to approve the budget now. The Commissioners Court approves our budget in September. Let me just finish. We only have the authority to approve our budget and recommend it to the Commissioners Court. What I'm suggesting is that we approve putting these dollars into our budget and we follow our regular process. And I've clarified with them that they don't need the funds to spend them, so we're still talking about money out of the next budget, but you're asking us to take an action we don't have the authority to take, and I cannot support that.
Okay, I understand that. David, can I ask your legal opinion on that, please?
On what aspect of that exactly?
She mentioned that we don't have the legal authority to take action on these dollars. Because
No,
we're
that's
not
not what I
appro-
said.
Because we're not approving the full budget tonight.
What I said was that I don't believe that we have the authority to finally approve the budget, because we are not, for fiscal year 28, because we're not the final approval of that. I do believe that we have the authority to say that we would like to put these dollars into our budget moving forward, and that we are, suggesting to our staff that they can act on that. So, I mean, you can move forward whatever you want, but I can't vote on this.
Thank you for that. Chair Rodriguez?
But we do need to, I want to get clearance from David.
Yeah. I have a question, David. So not to muddy the waters here, but because of the whole issue of the budget for FY27 needing final vote by the County Commissioners Court, could we, in the alternative, have the board direct the CEO to allocate the money from the contingency reserve if there's a need to hire these individuals? If we get lucky and you find the right person before the budget, would that be feasible, possible, legal?
Can you direct the expenditure of current funds? Yes.
From the contingency reserves, just to be direct.
So we can move the funds, this budget that's been presented, we could ask for it to come from contingency reserves for this round.
Okay.
But our motion would have to read as such.
Yes, you'd have to accept a motion to read
Yeah, that's
differently.
Just plain, so on, sir.
So,
I'm sorry. I would
And
hold on,
suggest,
let me
has a
just
question too.
see, just 1 second. Manager Malani.
Thank you. I was trying to go opposite of the muddy water way, and I don't know if it helps. So is the notion that there's a chance that we may need to do some spending pre-fiscal year, like a small bit of spending, and we want to make sure we're accommodating at least the understanding of that notion. So okay, it seems to me like it might be nice to do something like approving this budget for the foundation, obviously contingent upon full budget approval, and demarcating a 5% of that budget total that can be spent before the fiscal year, before the new fiscal year. And then, as far as the source of those dollars is concerned, I would defer to the chairs on that. I could I mean, yes, I'm sure that we could find the right source.
Thank you for that input. So with that, do you have a comment?
No, I was gonna, Ann had a comment about
No,
the suggested.
I've said everything I need to say.
Yeah,
Dr.
I
Martin?
agree with Manager Madwani. I think if we say that and then say that in case it's not approved for whatever reason, that then, as Geronimo said, that we have access to contingency funds, because I think we need to get this thing off the ground. So I think to paint it that way, I get what you're saying, Ann, and I agree with you, but I think at the same time, for expediency, to follow that, that we approve that, as Amit said, and then we proceed to have funds available if for some reason things explode the wrong way.
Okay, so with that, how, manager,
Ann has a question.
oh,
Do you have a?
No, somebody needs to say what we're,
so I would need an
Voting on.
amendment too. I just wanted to see the, so
Yeah, but
Manager
It has
Motwani,
to come from Amit.
so.
Yes, am I presenting an
Do
amendment?
you know,
Yeah. He needs
Yeah,
to
the
read it.
amendment was as, basically motion as stated, add the words provided adoption of the full central health budget, and then, add in the event, that any spending may be necessary before the fiscal year 27, then a 5% tranche or portion of the provision of the originally approved budget dollars, that full total, be available from insert source here for use.
okay, thank you for that.
That wasn't
The
helpful.
maker of the motion, do you accept that wordy motion?
I do.
Okay, so we have amended the motion, so I think we've had sufficient conversation around this item.
can you please read the motion again so I can
So
understand?
can you read the motion,
Want me to
full
read it?
motion, Manager May?
I'll read it as I added his stuff. Okay, the full motion reads. Per the foundation's legal formation documents approved May 2026, I move that the Budget and Finance Committee recommend that the board approve the proposed Central Health Foundation fiscal year 2027 startup operating budget, provided adoption of, I'll make sure I got it, provided adoption of the official, or adoption, no, I don't know my own writing, adoption of the central health budget, and that in the event spending is necessary before fiscal year 2027, 5% be made available by Central Health.
Okay, so that is the motion on the table, and we've had a second by Dr. Martin. Do we need a second for this one as well, for this amendment?
Let's see.
It
It's
would
the
probably
same.
be wise to seek a second, yes.
So
Yeah,
second,
let's get a second.
Dr. Martin, do you
So we
still,
can have
do you second
discussion.
it?
Second.
Okay,
Can I make a suggestion, friendly suggestion?
just really quick because we need to move forward.
I know, but this is important to get right. So instead of provided adoption, if, Amit, could you say contingent upon adoption? Because that's a better word.
Thanks, I was
Yeah.
brain
Okay.
farting,
So
sorry.
do you
Contingent on
accept-
adoption?
Yeah.
Okay,
Okay.
I accept it.
So we accepted, Dr. Martin seconds. I'm gonna take a vote. Do you have any comments or discussions?
Thank you.
Okay, all in favor, raise your hand.
Aye.
So, I see the motion passes unanimously. Thank you. We'll move forward. Thank you, appreciate it.
Thank you, appreciate
Thank
your
you.
work.
Thank you. Now, members, we're gonna move on to agenda item number 5, discuss and take appropriate action on Central Health System, Artificial Intelligence Oversight and Governance Policy. We will have John Morgan and John Clark who will be presenting. Members, this is the first time this policy is being presented to us. And today will not be a vote on this policy, it will be a discussion. And we will bring this back for a vote moving forward. And I see we have more friends before us today. So I just wanted to acquaint you all that we will not be voting on this AI policy. Yes, Chair.
Yeah, Chairman Maceda, one of the things I wanted to just mention is, you might be asking why there's a policy discussion in the Finance and Budget Committee. And what some of the members noticed was there's a $5 million line item on artificial intelligence in the budget. So we wanted to make sure that there was a policy in place before we passed a budget on a $5 million budget item. And so this is an attempt to do that, and so this is the first of time that as Chair Busaid mentioned, this is the first time we're gonna be hearing about it, so look forward to the conversation, but I just wanna give you context.
Thank you for that. I hope that we can start by our statute, that what, as governance, what we need, as a governing body, where we stand with this policy. So I hope that is part of your presentation. So with that, I'm gonna have you all start your presentation, and then we'll entertain questions with the anticipation you will be coming back in the future. Thank you.
Thank you, Chair. Good evening, members. I appreciate the time tonight, especially considering how busy of a time of year this is. And thank you all for prioritizing this item for us this evening. We're excited to share some updates with you all on our team's progress working towards developing a system-wide policy for your consideration. And before we get into the policy itself, we're going to do a little bit of brief level setting on AI itself, what it is, what it isn't, what AI looks like in healthcare, and some of the opportunities that we've identified for the responsible use of AI throughout our system. If you would go to the next slide, please. And one more. So we are asking for guidance from the board and feedback on the draft policy that was provided in your packet. Next slide, please. And as we're giving the presentation this evening, if you would just think about these key components of the draft policy and where you all might like to weigh in. The policy today drafted really outlines roles and responsibilities across the organization. It gives very specific prohibited uses of AI in our system. It retains responsibility for human oversight and responsibility for any AI in our system. And it gets into some of, I think, Chair Musaitif, what you're referring to is there are a lot of laws and regulations, and it's a rapidly evolving environment around AI and AI in healthcare. And part of what our team has been doing over the past several months is trying to braid the different requirements around AI that apply to health plans, healthcare providers, and governmental entities in Texas. So we've got to meet all of these different requirements as a system that's on one shared technology platform in many cases. So we're excited to share our updates. And before we dive in, I'd just like to do a very quick introduction of our team here. Joined John Clark, you all know, our Chief Information Officer. You all have heard from Sarita Clark-Leach, our VP of Data Insights, and oversees the components of AI that we will be talking about around monitoring, around data science, some of our predictive analytics. And then two new faces that you all probably have not met before. Would like to introduce Kuntal Senda, who over the past 3 years has been helping develop the revenue cycle infrastructure that we need for Central Health's direct practice of medicine. And over the past several months, she stepped into a role that's been bringing us all together as a system to have the discussion with our legal and compliance folks around this AI policy, and also helping to develop some of the structures that you'll see outlined this evening. And then Anuj Tiwari is new to the organization, just a few months in now, but Anuj brings a wealth of experience from real hands-on strategic and operational AI implementation across multiple sectors. So we're really excited to have him on board and have his expertise helping us get into this area. So I will turn the presentation over to Kuntal.
Can you all hear me? Thanks for having me here. Can you switch to the next slide? I'll attempt to answer the very basic question here, which is also the most burning question at this point. What is AI, right? So the simplest way I can explain, there's a lot of factors to it, obviously, but the simplest way I can explain to it is, have you all used calculators, right? There are two pieces to calculator. One is algorithm and data. Those are the fundamentals of AI. There are several other factors to it. Fast forward to now, you're looking at not only just data and algorithm, now you have a decisioning piece to it. And so that becomes smart. That's the intelligence that's built into it, right? What does AI do from very fundamental basics is it learns from the data, the algorithm uses it and produces the new information. Why is that important in healthcare, and why is it so important and so prevalent in healthcare at this point as we are growing? Because healthcare sits on a lot of data, several amount of data, and it has a lot of processes, a lot of standard processes, a lot of evolving processes, and those two pieces really are prime for AI to be working in this. Next slide, please. Before we jump to the next slide, the biggest piece here for the first slide was we are not replacing any individual. Just like calculators never replaced mathematicians, it added accessibility to math. Same thing. AI is not replacing anything here. It's more in the form of, can it help? Can it exaggerate? Can it help people make equal decisions? And that's what this slide kind of talks about. There are several ways you can split AI. The one that we prefer to is by functionalities. The reason for that is we have certain tiers that we build together, and these all types of AI sort of plug into that. The very first one is, again, going back to the calculator example, automation. Calculator was able to do certain piece of it. Now you improve automation. Now you improve the data as well as algorithm, make them even smarter. That's smarter automation. It can take a lot of information. It doesn't learn, but what it does is it can make things faster and more accurate. Healthcare is using some of that piece already. It's been using that for a long time. The next part comes to the predictive part of it. It's used same example. You have data, you have algorithm, and then now comes the decisioning part. Predictive analytics can look at a lot of these information and predict, and then the decisioning starts to happen. So it can evolve now. It's more smarter, more fast, and still it can learn, but there's a slow process to predictive analytics. Then comes the generative AI, which is the most important work right now. What makes that different is the fundamental part that now it can use different types of data, and it can learn from your information. That's where the large language models come into picture. They can learn from all your inputs. That's what you're using in ChatGPT. That's what you're using in all of those pieces. And it can start to give that more accurate, more tuned in information. The last part there is the agentic AI and autonomous AI. They're both sort of similarly related. The fundamental difference between agentic and autonomous AI is the autonomous AI can do a lot of decisioning. And that's what makes a separation. Agentic AI, on the other end, can do decisioning, but in a controlled manner. The autonomous AI part of it is especially focused on humans on the loop. They have built everything, they have put together pieces, and they can now let the system run. That's the next level. There are pieces to it that's already been in work, and the agentic part of it is you can use those. Contact centers are using it right now. A lot of pieces in our systems, not in our systems, as in healthcare, is using it. That's the agentic part of it. Next slide, please. So how is it in the healthcare landscape it's playing out? And I'll just touch base on one of the administrative aspects of it, the contact center. Contact center right now uses a lot of AI. That's where my strength is. I've done a lot of stuff in contact center. When somebody calls in, an agentic AI takes effect. It can call in, it can understand what the call is about, and it can start to figure out where the next step is. That's where the decision AI comes in. It can look into it, understand, and this is the combination of generative as well as the other pieces, and it can decide what to do next. Once that happens, you have in the background you have conversation AI, which is listening to your information, which is trying to predict, which is trying to understand what your sentiment is, the human aspect of it. As you learn more and more in ChatGPT, you start to see how it starts to take sentiment analysis to it. The other part of that is the execution aspect. When that happens, you have the execution layer as well as the compliance layer comes in. So all of those different types of AI are working in that one segment. That's incoming call. When you're outgoing and talking to a patient, it can use predictive AI. and it predicts, hey, this patient may have some sort of diabetic challenge, so you can call that. That's the other side of AI. So in all, AI can be used in different forms, and it's been used in healthcare and other aspects across the industry. With that, I'll turn it over to Kuntala, my diet partner.
Thank you all for the opportunity to speak today. I think what's really important for members of the board to know is use cases, examples that really are meaningful to our patient population and our community that we serve. So there's two examples I want to bring to the board's attention, especially as you look at the AI policy, the draft policy, to keep these in mind, because this is the potentiality and where we want to go as a system and as each entity. So one is just down the road on I-35. You all know Parkland Healthcare District very well. They have a innovation arm called CCI. This innovation arm has multiple AI technologies that they have developed, and they also do other technology pieces. One of the things that they had created using AI model is something called Parade. And Parade is a AI technology. So and let me actually say what the acronym stands for. It's Patients at Risk for Adverse Drug Events. And the example that they use and the intervention they use is when a patient gets admitted within the hospital, they run this AI model to identify patients that have the potentiality of having an adverse drug event. And because of that algorithm, they inform the clinical team and the pharmacy team early on in that patient care's journey to make that meaningful intervention to ensure that an adverse event doesn't happen. So Parkland actually shared in their research and outcomes-wise that intervention alone allowed for prevented close to 2,000 adverse drug events. In addition, it saved approximately $17 million across the Parkland system. So again, examples that we can use and also to be thinking about as our system. Another one to think about is at Cleveland, Ohio, in Massachusetts, there's another public safety system that actually uses predictive model to flag a patient that was at risk for not showing for their follow-up care. And what they did is, because of that flag, did high-touch interventions in ensuring that the patient, because of that high touch, they actually proved out that they were able to decrease the no-show rates. So again, as you guys are looking at the policy, the draft that put forward before you is to really to be able to allow our system to consider technologies such as this. Next slide, please. So our mission, so again, bringing us back to where we are today, in our current environment today, we do have AI embedded in multiple applications. Examples are in our EMR system. So Epic, as you know, is our EMR system. With every single release, there is technology. There's already AI-enabled features that are part of the upgrade. Other examples are, our emails that we use, and Microsoft and all the applications that we use. There already AI is part of that. And so really the call to action here is, because it's already an environment, it's our responsibility to make sure we have that oversight, that right size oversight, to ensure we use AI responsibly. And using AI responsibly, having it have that right kind of oversight and using it responsibly really helps further our mission and our value. And examples of that, of our mission, is, again, just in the mission space, really looking at strategic priorities across our patient access, looking at our strength, coordination, increasing operational effectiveness. So really that value piece is really crucial. And in the policy, what you'll see is that balance, right? To making sure that we have the requirements in there, but we're also able to, really more importantly, really stand behind our mission, our value, and the care that we give to our patients. Next slide, please. For the board's awareness, you had asked the question about what are the regulatory requirements and making sure that we adhere those. There's 3 different levels for the board's awareness to consider. One is the federal level. At the federal level, there is various agencies that we are responsible for, we have to adhere to. The 5 that to call to your attention is the FDA, looks at the regulations surrounded medical devices. CMS, as you all are aware, with Medicare and Medicaid, and they have specific regulations around authorization and coverage termination. ONC really sets the standards for how transparency requirement as it relates to AI into the technology space. OCR is in the space of making sure that we enforce non-discrimination. We have privacy, security, and FTC addressing making sure we protect the health data side of it. And again, in the policy, you'll see those particular regulations specified. Next slide, please. What's unique about us is that we not only have the federal requirements, but we also have this balance of making sure that we adhere to the public entity side as well as being a healthcare provider in our community. And so there's multiple regulations that we are accountable to as a system and as an organization. From a provider perspective, we are responsible for making sure we protect our patients' privacy, we prevent discrimination, and ensuring that we effectively disclose to our patients that we are using AI. On the public entity side, we also are responsible for making sure we have transparency, we are responsible technology, we have ethical standards, which I'll dive into an example here in a second, and make sure, again, we have that appropriate oversight. So as you review the policy, those standards you'll see are addressed and for your review. Next slide, please. This is one, just a little bit of deeper dive down into one of the regulations on the AI, on the public entity side. So this is from DIR, which requires us to adopt our AI code of ethics. And this is a mandate for us. And again, as you see those regulations and regulations that come through, these are things that we have to adopt as the type of entity that we are. And one of the things for this board to be aware of is the draft policy that is before you. Know that is inclusive of so many voices from staff from Central Health, but also within Sendero team, our CUC colleagues, and we have worked with our compliance and legal team to ensure that the draft that's before you does address all the different criteria and the regulations that we have just covered in those 3 different layers.
Kundal, could I just add, for the board's awareness, a lot of the requirements you see here around the code of ethics and the local governmental entity requirements were based on the last legislative session, and DIR is just in the past few months rolling out new rules and regs that operationalize what was passed in the legislative session.
All right. Thank you.
Next slide.
Yes.
Kundal talked about the regulatory and the responsible AI. National Institute of Standards and Technology, the NIST framework, has been around for approximately 100 years, if I'm not mistaken, and has been a benchmark for IT. They also came out with AI risk management framework. It is a nationally recognized framework and internationally followed framework. GDPR from across the pond also follows a lot of this piece as well. The fundamentals of this framework are really 4: to govern and manage the risk, map the risk, measure the risk, and really manage the risk, essentially. So the governance part of it is critical. Anytime you have an application or that uses AI, what are the risks? Understand that, map those risks, and how can you manage it and then measure it. And that's the fundament. That's a cycle that keeps going on as long as there's an AI life cycle attached to it. It's a standard across the industries, not only just healthcare, but government, tech sector. One of the biggest reasons we picked this one is a lot of vendors are starting to use this as a framework. What gives us this opportunity for that is we can use that same model, same framework, and measure the vendor's ability. And then it's a plug and play when it comes to vendor implementations, right? And then fundamental part of there is it really helps protect patients' information, takes care of the security. So I think those are like the fundamental piece here. Next slide, please.
So trustworthy AI doesn't begin when a model goes live. It begins with disciplined vetting before the solution is introduced into our environment. First, we assess the solution, the vendor, and the specific use case, not necessarily in that order. That means clearly defining what the tool is intended to do, who may be affected by it, how success will be measured, and what levels of risk it presents. We also evaluate the underlying data, privacy and security protections, regulatory requirements, and whether the model performs consistently across different populations. Ideally, implementation should move forward only when the solution meets established performance and risk thresholds. Second, we launch in a controlled way with clear accountability and human authority. We establish ownership, approval requirements, audit trails, and escalation points. When appropriate, we begin with the limited pilot, validate real-world performance, and gradually scale. People remain responsible for reviewing and acting on consequential outputs. Finally, deployment is not the end of the process. We build in observability so we can understand how the model is operating, what data and outputs are being generated, and where issues may be emerging. We continuously monitor utilization, efficacy, safety, model drift, and disparities across populations. If performance falls below established thresholds, we investigate and act, whether that means reconfiguring, retraining, suspending, or retiring the solution. Applying a standardized lifecycle approach allows us to deploy AI judiciously, safely, responsibly, and effectively. Next slide.
How many more slides do you have?
Just four. Is that okay? We'll just breeze through this real quick. This is our from our CUC colleagues, and this was put together by Dr. Karen Walsh. This is the ambient DAX AI from Epic that was in pilot and that was ultimately went into production. Improves the efficiency and wellness. As you can see in there, it talks about physicians and how physicians really help their this particular tool help them direct their work towards more patient care. Next slide, please. The EHR experience outcome, which is measured in NEAS, which is a net EHR experience score. As you can see, the top four there is the reduction in the time and hours, which ultimately helped improve the job satisfaction and those sort of measurements for the providers. So this was one of the use cases that was launched on with community care. So next slide.
The next one is an example, again, in our environment. Our Sendero team, who's in the audience today, you may have already heard this story, which is in 2025, they had an increased volume of patients and members that had called because of an increased enrollment. And using AI assistance, they were able to effectively they used AI to really help with the call volume and do it effectively. And that really has turned that visual that you see right there is really just to show a different level of the due diligence it takes in order to implement a technology solution. And so that's what we really want to bring forward in this example is not only was the AI use case, AI agent really effective, but the due diligence it takes to implement something like this that really also ensures that it's safe, it's meaningful, and it's effective for our patients and members that we serve. Next slide. And I'll just read off one stat, knowing because of interest of time. The Sendero team shared with us, just their AI resolved close to 40 to 50% of their calls. Again, the customer service rep is still involved in the process. They handle more of the complex type questions, and AI is really able to help to augment and support more of those easy questions and really be accessible for our members. And you can see as well, they're available 24/7 for them as well. Next slide. This last slide just really highlights the potential use cases that we're considering across the system. Really, the first core important piece to pay attention to here is that it's all with the same goal, that we're focused on helping our patients, our members, and our staff. That's ultimately the core. And doing that responsibly. So the categories that you see here are things that, looking at tools that will help reduce administrative burden on our staff, making sure that our care team has more time, looking for ways to ensure our community has easier access into our system. And lastly, making sure that we are considering meaningful interventions, using AI to help us identify meaningful interventions in that patient's care. So as you look at the policy, know that we've included a framework that's really to explore these opportunities thoughtfully, responsibly, but again, really based on and grounded on our core and our mission. And with that, I think we have one last slide.
Yeah, I'm going to try to wrap it up really, really quickly. So as y'all can see, there's been an extensive amount of work, probably a year's worth of work that has gone into just understanding the uses of AI and the regulatory requirements and the different aspects of how AI might be formulated into a healthcare organization. We've taken a lot of care to understand that first and try to really put some framework around how we are going to move forward with AI as an organization. There is a value to using AI in healthcare, but we got to strike a balance between that value and the risk to the organization. And we got to make sure that the policy that we have in place and that we have presented to you tonight actually allows for guardrails and the boundary conditions to be put into place for us to move forward in that responsible fashion. I think that without going too much further, this team has come together over the course of the last several months here and has really started moving the ball forward, moving the ball up the mountain. But it should not be lost on anyone that AI is already within the fabric of Central Health, and that part of trying to establish this policy is actually trying to also put some guardrails around the current uses as well as what that future use looks like. One last thing, I know that I heard a couple of comments about the budget line item. I want to make sure to clarify, there's a $5 million ask within the budget that actually does not just consist of AI. There's cybersecurity stuff put in there. There's also dollars in there associated with just the foundational infrastructure, network components, and other things that we have to do to manage the environment from a technology perspective. And then the AI components are really around consulting dollars and the infrastructure, the server infrastructure, the data infrastructure that is there to support the use of AI in our environment. And I think the total of those two components, the consulting piece and the dollars associated with the foundation, is roughly about $1 million worth of budget ask.
Well, thank you all for your presentation. We have two members that actually, could you state your names?
Oh, yeah,
First time
sorry.
you're coming for us.
Yeah, I'm Anuj Tiwari.
Kuntol Sanda.
And your positions?
I'm a Senior Director for AI and Digital Innovation with Joint Tech.
And I am on the operations side of AI.
Okay, thank you.
Consultants, or are you on the?
We're part of the central health team.
Thank you.
Okay, so members, I think it is in a governance structure to know what touches the patient. So that's our role, and AI is one of them. And to ensure we have guidance from us as the board, how we would want the organization to use AI. So I think that's a foundational where we're at. We are not disputing the importance, the significance of AI. That is absolutely not the case here. But we want to ensure the guardrails, that it is, especially with patient data, the privacy, and ensuring that ultimately who's making the decision in patient care is the physician and not solely relying on AI for that decision making. It assists, you mentioned augmented, but it's really not, it's about patient care and trust in the care that we deliver. So ultimately, that's just my spiel here. Now, the policy, whoever drafted it, done a great job. That's a great draft and a starting point. There's a lot that probably we'll need to add and include. So one is a governance question that I'm not sure if someone pointed out because it spells out the system CUC and Sendero, and both, I just don't know if that needs to go, if it needs to be separated. So I don't want to speak on their behalf of what they've established. So that, to me, maybe we can touch base later because it's stated in the policy. Second, I think we need also to ensure that we have a list of all the AI, tools, who's accessing it, who's using it, and ensuring the proper training is completed before access. And also a policy around the statement about personal devices and their uses of AI that impact their day-to-day work. So I am gonna stop here, and I know there's a lot of questions coming back, but also in terms of legal, we would want to know who was part of the legal, who actually looked at the legal to make sure that it fits in our context here. So I am going to open the floor for board members. Manager Jefferson, do you have any comments? And we'll go around.
Yes, I use AI all the time. I know it's just a part of our fabric, so I understand it's being used. The specific asks in the budget, one of them relates to a piece of software that looks like it's in the HR space for recruitment and benefits. And so I don't see anything really addressing that. And I understand AI is helping everybody do their work well. I would like the policy to, when we have something like that, to make sure that it is not completely so automated that, that the software, well, first of all, if the money's in this gets back to, when we make a proposed budget, to me, we're not authorizing the exact purchase, and I would like that to be clear from the chair, not at this moment, but later. So I understand money's being put in there, but if there is a particular piece of software, I just want to make sure that, it's been tested because, there have been some reports of some of these things having the bias and that kind of thing. So just want to point that out. I didn't see any attention paid to the HR aspect of it. And then living in the world myself, I certainly have called my medical providers, one of them, and been just completely annoyed by talking to a machine that would not let me ask a question that was not within the stock form of responses. And I just hope that we have some kind of customer survey aspect to these things to make sure that we're doing it, especially, I think of the people with whom I play bridge. They would not be wanting to talk to whatever name is assigned to the machine. Okay.
Thank you. Manager Kitchen.
I just wanted to ask, and if you could provide us, not now, but if you could provide us in a simple form, a table or a list, the risk and what's the guardrail we're proposing to address the risk. And you may have some of that embedded in what you presented to us, but I'd like to see it in a simple form so we can explain to ourselves and our public what we recognize as risk and what we are putting in place as guardrails.
Thank you. Manager Kitchen, Dr. Martin.
Thank you for the presentation. I have several issues. I can appreciate AI as a tool. I think that if it's used as narrow intelligence, it's very beneficial for the administrative task at hand. As a doctor, I have real issues with AGI in medicine. I think the issues of transparency with black boxes, the model drifting, there's so many nuances in that I'd be very fearful effect on our patients would have, and also effect on the physicians. This can be education destructor to some extent if those issues are not addressed to some extent that we need to have. The issue is sort of what humans watching the human that's overseeing this. That's a real issue. And I think AGI, especially in healthcare, could represent a real problem, my personal opinion. You mentioned about doctor burnout, and this is an aside. Dr. Brinson, I will tell you, you receive artificial intelligence notes from consultants that are 12 pages long, and all you're looking for is one sentence at the end, because it's just a bunch of crap. And this health record system has become a billing tool, not a medical tool. And I'd argue that as an organization, we should perhaps get focused back to the medical information that the doctor needs, not whatever the bill may require. I don't know about you, I've never had a bill rejected in my medical career. And I think that if we do this correctly, I think that's an enormous source of, that is the source of burnout, because people generate these 12-page notes that are silly. But I just want to express my real concerns about AGI in healthcare. I think as administrative stuff, security issues, it's an incredibly invaluable tool, but AGI could be an issue in medicine. Thank you.
Thank you, Dr. Martin. Manager May?
I have no questions.
Chair Rodriguez?
Three really quick ones. I think one is more practical. One from a governance perspective, the Texas Open Meetings Act. I don't know if the software that we're buying is going to include AI, so I just don't know whether that's a relevant statute to add in here, because you know how some of those, I don't know if that software will be consolidating our comments into meeting notes, but that's one. Two, just on a practical level, like I know you mentioned cybersecurity, like just tell me from like a practical level today, we've got what, 1,200 employees? Are they able to use Claude, ChatGPT already on our computers, or how are we protecting not just the patient data, but just our systems from any one of us using what's now on our computer, or plugging in something and using it there? Or do we have guardrails right now? Do we have protections there right now?
Yeah, I think from the standpoint of a sanctioned tool that we use, there is certainly Copilot within our Microsoft environment. And through Copilot and Foundations, there are actually ways that people can utilize the tools within Claude and some of the other large language models, but it's limited in that scope. There are certainly people who are utilizing some of those resources and tools within our environment who have their own personal accounts with some of these systems. And we're doing our very best to control what people are actually doing with that. I think part of trying to get a policy established is to prevent the continuation of that.
Yeah, and that's what I was getting to. I think the one thing that I don't see in the policy is about prohibitions, or who has the authority to prohibit certain types of AI. I don't think we probably have the expertise to do that, but you need some authority in the policy about prohibited uses or prohibited AI that's like from a personal account, like if somebody's using that. The third one, it really goes back to, I think, I can't remember who said it, like the legal review of just knowing who did the legal review. The other part, I think, is a integration issue. We've had outside counsel working on some procurement contracting policy changes, and I think one of the things is to have them look at this, because this talks about procurement and deployment and use in accordance with this policy, but we're about to make changes to our other policies. It's just a matter of just a little of a review of integration. But thank you all for the hard work. I know this is an area where it's like the unknown, but I appreciate the guardrails that you're putting into place.
Thank you, Chair. Dr. Brinson? Manager Matlani?
Y'all did a great job. Thanks. Just having those principles is a good spine. And then, of course, like statutorily, y'all covered it pretty damn thoroughly. That's really good. Even down to TDI when we're talking about some of the notions with Sendero. Though I still think that question is worth unpacking, to be clear. Now, with all that said, I think, the question that Chair Rodriguez asked is really salient, and I think the answer is equally such. And to me, although this may not be the forum for that discussion, I still want to scratch the scab and say that we really should do our best to not have, as any company should to not have staff using their personal, even if they're subscribed AI subscriptions. I know staff are not entering patient information into these systems, but nonetheless, in the same way, just business operations information that it's clearly not a best practice, and you know, I would encourage continued movement toward, as you're doing, like enterprise side agentic solutions for every single staffer, such that they're not incented to use their own. You can have the prohibition, but the prohibition is only one part. The incentive alignment is the other, and we don't want to tell people not to use an optimization tool to optimize their work. So there's that. And then the other thing that stands out to me, again, I don't think that this needs to be belabored at this point, but I think it's part of the journey, which is, you know, sort of how board governance with AI Council and all that, like what that perpetual feedback loop looks like. But thanks for bringing this.
Thank you all. So, as you all heard, I think the board is all in alignment with AI and future use, but I think what we're coming in is how we want to use it and ensuring that we have a policy in place that protects and the guardrails. So I kind of, and I'm going to say this out, like I felt like you may have probably started implementing these AI before we've drafted a policy. So I would hope that we can finalize this policy as we move forward to ensure that we're protecting our patients' privacy and organization. And also as we're moving, I think the chair just left, in terms of the contract, I think that should be explicitly moved forward, that whoever we're contracting with should understand and follow the policy that we have in place as well. So we will definitely, you know, board members will come back for any feedback, but I think you've kind of heard where we all stand in moving forward with this. Thank you, appreciate your time. We will see you again.
Yeah, for sure. Thank you.
Sure, thank you. Members, we are going to go into closed session for item 6 for a few minutes.
6, 7, and 8, may as well read that, right?
Should we, you know what, let's all go back and then we'll have a presentation coming back. I think that will be easier than going back and forth. So we're gonna go into closed session for item 6, receive and discuss a presentation on the proposed fiscal year 2027 tax rate and budget for Central Health. And that is under Texas Government Code 551.071, consultation with attorney. And for item number 7, I just want to make sure that I read the code correctly. Receive and discuss a presentation on the proposed fiscal year 2027 budget for community care health centers. And that would be under agenda item 7, under Texas Code 551.071, consultation with attorney, and Texas Government Code 551.087, 551.085, governing board of certain providers of healthcare services. And for item 8, receive and discuss financial and operational updates from Sendera Health Plans, and that is under Texas Government Code 551.071, consultation with attorney. And then we will come back for the full public presentation of our proposed fiscal year budget.
Could I ask a question?
Yes.
It would seem that the tax rate discussion is in part a public discussion.
Yes, it is, but there is some legal consultation that we are going to be receiving.
Okay, but then we will be discussing the item in public.
Oh, yes, yes, yes.
Okay,
but
great.
there's some legal guidance that we are going to be
That's
receiving.
fine. I just wanted to make sure that it didn't sound like we weren't
Oh,
gonna
no.
discuss it.
It's just some legal. And it is August 26, 2027, and it's 5:36 p.m. And there's food if anyone wants to grab it. Okay, are we back? Thank you so much. Thank you, everyone. We're resuming our meeting. We're back in open session. Today is still August 26, 2027, and it's 7:09 p.m. We deliberated briefly on agenda item 6, and where we were going to have another presentation out in public. We discussed items 7 and 8 and gave direction to staff for item 8. So with that, we're going back to agenda number 6, receive and discuss a presentation on the proposed fiscal year 2027 tax rate and budget for Central Health. Members and the public, I think something that we need to really, we are all volunteer board members, and we are on this board for a
Recording in
reason.
progress.
Okay, so as I mentioned, we are all volunteer board members who really invest a lot of our time, our effort into ensuring quality health care is delivered for those who need it most. So, each of us have that passion, and I can probably speak on everyone's behalf. So with that, this is really and we're almost halfway into our budget process, where we've had multiple deliberations on how we can better serve our patients in our community, and also build collaborations across the city and the county to ensure quality health care is presented for all, and especially those who we are for the poor and those who are under 200 FPL. With that, I will, and also something that I personally carry a lot of the definition of health, what it is, and based on the World Health Organization, they define health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So to me, that's how I believe what health is mind and body, and I think without those two, we cannot have good health outcomes. So with that, I am going to open the floor for our CEO to make a few remarks, and then for our staff's presentation. Thank you.
Thank you, Chairman Saitief, and good evening, members and members of the public. We are approaching a critical decision point around the Central Health budget, and staff is prepared this evening to walk the board through a range of key options and risks of each of those options. The choice is before the board, and none of them are easy, and all of them will be consequential for the health of our community, the mental health of our community, and the total value that we are able to add on behalf of the public over time. In framing tonight's presentation, I want to share 3 framing thoughts. The first is around affordability. We are acutely aware that costs are rising, inflation is exacerbating this. There is very little to no appetite for increase in taxes. I know the entire board and all of the staff are very sensitive to the conditions of affordability at present. Point number 2 is around listening. This process includes a great deal of engagement with community members, community leaders, elected officials, all of you on the board, as well as a range of data emerging through our demographic report, through the community health needs assessment data that is coming in. And yesterday we received a letter from our mayor. We'll be giving you a hard copy of that just for your reference. That letter also references No Wrong Door, which is a multi-stakeholder initiative that many of us have been engaged in. We provide an informational handout from the city on that as well for your reference. But I want to share the number one finding or signal that comes out of all that listening and the data is that the key gap before us is around behavioral health. There's an acute need to provide behavioral health care for individuals who otherwise, in the absence of that access, will find their way to our emergency departments and hospitals, in many cases to our jails, and in many cases homeless on our streets. behavioral health care is directly connected to ED utilization, jail utilization, and homelessness. Which brings me to point number 3, which is around Central Health's mission and our commitment to stewardship for the public. To outline this particular part of mission and stewardship, I'll actually point to the mayor's letter in which he lifts up some information that the chief of police has shared with us. There was a woman that, in particular, amongst the No Wrong Door population, has been arrested 19 times, by the Austin Police Department. That's just one person with mental health needs amongst 950 approximately individuals who are just as high utilizers in our community, meaning they experience arrest more than twice in a 2-week period. 950 individuals in our community have been estimated to cost our community about $137 million per year in those downstream costs. And so how does that relate to our mission and stewardship? As a public health care system, our responsibility working with Integral Care and others is to ensure that the behavioral health care access is optimally available as an alternative to ED, street, and jail. And by doing so, we expect to have a meaningful impact on the 137 million and other downstream effects in the absence of behavioral health. And so with this information in mind, staff has been sharpening our pencils for weeks, and also, or especially the last couple of days, in light of the mayor's guidance and feedback to us. We are going to be presenting a refined proposal for the board tonight that accomplishes 4 things. The first is to explicitly and specifically link the Central Health FY27 budget to the components of the No Wrong Door multi-stakeholder work. The second is to explicitly link the FY27 budget to the future mental health crisis care center work that the board has been apprised of and that is ongoing. The third is to bring the known commitments that we have forecasted for the board in the out years, in the future years in the Health Crisis Center into the present year, so that we can see the components of the FY27 budget that relate to that future effort. And the fourth is to clearly and specifically answer the question, what is the value for the public of the Central Health budget at 8% as opposed to 6%? So with that in mind, staff will walk through details tonight of a 2-part refined proposal for mental health.
Yep.
The first part involves inpatient psychiatric capacity. The proposal that we want to bring to the board's consideration would be to consider accelerating the build-out of approximately 22 inpatient psychiatric beds at Dulce Medical Center, paid for by Central Health. We would also explore whether or not the current ED can accommodate up to 10 psychiatric ED beds, but that requires analysis of any impact on mass casualty response. And we are proposing, based on early estimates of that cost, a $20 million commitment on the Central Health budget. The second part of the proposal relates to the operating costs of this work. We estimate approximately $8 million a year to operate those 22 inpatient beds. And the board is aware that on the Mental Health Crisis Center proposals, there was an approximately $6 million operating gap that did not have a funding source before then. So with that in mind, staff is proposing that the difference between 6% and 8% on the Central Health budget, which is $7.3 million, that be placed into a mental health operating reserve. That $7.3 million, as it compounds over the years between now and when the services come online, our estimate is that should cover or meaningfully offset those operating costs. So what does the public get between 6% and 8% on the Central Health budget? We would get funding for future mental health crisis care services. As the board is aware, we have retained John Hawkinios, a TXP, to perform economic analyses so we can more specifically tie how this work would affect the $137 million estimate on No Wrong Door. And finally, staff has will bring forward an options and risk tool for the board's to help with board discernment. This tool will allow us to dynamically model different tax rates across different years and see the effect this will have on the central health reserves, as well as the central health opportunity capacity. You could think of this as the inverse of opportunity cost. What is the central health system able to accomplish under each of these scenarios? So we'll be showing that to you as well. Tonight, there are three linked components of the presentation. First, the budget presentation, which you will hear shortly. Second, in the early part of the Board of Managers meeting, a deeper dive on the mental health care continuum and those components that we mentioned a moment ago. And finally, the discussion and vote on the public hearing tax rate that the board wishes to post. And so with that,
So,
Could I ask a question, Chair?
yes, Manager Kitchen.
I don't have a piece, I'm sorry, I would like to see a piece of paper about the proposal that you just laid out. Is there a document that we can look
So,
at?
let me answer your question.
Okay.
I don't think we have received any of them. This is quite surprising to me. Just FYI, we don't have a proposal before us, and so just letting you know.
It's hard to follow verbally for me.
yes, we will be walking through all of these components in further detail.
Can we have a copy of the presentation then?
We can print a copy.
If what you just laid out, Dr. Lee, is in it, that's what I'm interested in, so.
Is it in the packet?
The budgetary components we will be covering now in this presentation. During the mental health item on the Board of Managers agenda, we will be covering the mental health components, much of that in open session and also a component in closed session for the board.
Okay.
That was,
Okay, Jeff and everyone, do you have something, Manager May?
I'll ask it after the presentation.
So if you can proceed with your presentation.
Next slide, please. So real quickly, our agenda as it relates to tonight, at our Board of Managers meeting, we will be asking for a proposed tax rate for the public notice, and we'll also be requesting approval for the public hearing time and location. I just wanted to add, we've passed out a few sheets of paper. One of the things in the packet presentation, there were some outstanding questions that board members had. They are included in the agenda packet that you have. I know we had some fairly new questions that we may not get to, but we will get to those at the next meeting. Thank you. I'm going to turn it over to Nikki for a few slides related around our property taxes and our engagement process.
Good evening, Nikki Riley, Deputy CFO. This is a slide on listening, engaging, and connecting with our community. As Dr. Lee noted, listening to our community is extremely important to us, and it's a foundational part of our planning and budget process. This slide highlights the many ways we engage with people across our community throughout the year. We hope these engagements demonstrate a genuine commitment to community involvement with our patients, community members, partners, leaders, and elected officials. We look forward to continuing our engagement at the fiscal year 27 Strategic Priorities Town Hall with Judge Brown next Monday. This slide you've seen before. It was in the August 12th presentation. It is the median homestead impact under each scenario that we are proposing. The 6% and 8% are exactly the same as they were on the 12th. However, the no new revenue rate is a different rate. We got with Travis County and they advised us on the no new revenue rate that they wanted us to present. Yes.
That's in the backup.
This is in the packet.
Yeah.
Yes. And so you can see then they have the same, no new revenue rate has the same debt service rate and the same amount. And then there's also an M&O rate that is separate. We also added the annual increase to the median homestead taxpayer, so you didn't have to do any math. So the no new rate increase is $10, 6% is $36, and 8% is $44. Any questions on that?
Does that conclude your presentation?
No.
Okay, so, continue on, thank you.
Next slide, please. Okay, there are a lot of numbers on this slide. I'm going to try to explain it rather quickly. The first set of numbers I want you to look at are the bottom numbers where it shows you the categories of each column. Under 150,000, 150 to 250,000, 250 to 350, and so on. Those are the categories that we received from TCAD on the number of homesteads and their values for each of those categories. What we did is we took the average of that value in that category times divided by how many parcels are in that category to come up with an average value. So that when you see the percentages at the bottom, 17, 16, 22%, that's the percentage of all the homesteads of what that category is. So 17% of all homesteads are under $150,000. The second set of numbers I want you to look at is the red percentages. That is the projected, that is the percentage change in the property value. So the property values under $150,000 went down 32% this year for tax year 2026. For 2020 fiscal year 27, they went down 17% in value. The next category, if you own a home, 150,000 to 250,000, on average, it went down 16% this year. Every single category went down, except if you owned a home over $950,000. That category went up by 2%. Overall, homesteads went down in value this year. So there's that percentage. Now I want you to look at the dollar amounts that are on each column. So the negative $22 for under $150,000. That is the projected increase or decrease for a homestead if we went to 8% over no new revenue rate. So on average, their tax bill is going to go down by $22. If you own a home between 150 and 250, on average, they will see a $10 increase. The next category will see a $29 increase. Next category will see a $43 increase on 8% over no new revenue rate. Over $950,000 home, if you own $1 million home, on average, you're going to see a $312 increase in your taxes with 8% over no new revenue rate. We wanted to get into the detail on, we can say on average what homesteads are going to go up, the median, but this gets more into the detail of the categories. If you own a home, what the value is. 55% of homesteads are in the first three categories, under $350,000. Any questions on that slide?
I have a question, and so this is Central Health's own cost to the taxpayer, correct? Only. So we have the city and we have
Correct.
the county. So in the school district.
Correct.
So, given where things are for those who own a house within the last buckets, like what is the the increase for those individuals?
Well, I'd have to know the increase in property tax for all of those other entities. But as a whole, property values in Travis County went down. Even if we stayed with a no new revenue rate, their taxes are going to go down. And so at 8%, they're going down. Most likely, most people's property taxes are going to go down.
But they're going to see a rise in taxes for those individuals.
They will not.
From
On
all the
average,
other-
they will not.
Okay. Manager Kitchen, you had a question?
This doesn't account for exemptions, right?
I'm sorry, for what?
It doesn't account for exemptions, right?
Exempt property?
This is before,
Homestead.
this is before.
This is taxable value.
Okay, taxable
So
value.
yes, it does.
Okay.
Okay, you can continue.
Okay, next slide. I believe you wanted to see some comparisons to other hospital districts. We looked everywhere for information. Some of them hadn't gone to their boards yet. There is a Truth in Taxation website where they are required to put in their proposed information, their tax rate for debt service, which is a calculated number based on the amount of debt service they have coming up the next year. And then their M&O rate. So that is where we got this information, is from the Truth in Taxation website. You can see Travis County, 8% increase is what we're proposing. Bear County proposing a 17% decrease. They're basically keeping the same rate as last year, but their debt decreased, and so probably moving a little bit of their tax rate from their debt rate to their M&O rate because they're keeping the same rate. Dallas County, their Truth in Taxation was different than, I believe we got some new information today. They're keeping the same rate that they've had for the last 2 years. I believe their change in tax bill is going to be $47. Sorry, I didn't explain the chart. The very last column, the change in tax bill, is what their increase or decrease in taxes will, how it will affect each homestead. On average, this is average, by the way, not median. So Dallas County, their change in tax bill is $47 based on the new information. They are going up 8%. El Paso, down 2%, with a $21 increase. Just a little bit aside on El Paso, their bond rating was downgraded in March, I believe, this year due to a weak balance sheet and I think some cash flow issues. Harris County, they're going at 4%. With an effect to each homestead of $149. And a little bit more about Harris County. Last year, they also went up 8%, and the year before, they went up 9.5%. And the last one is JPS in Tarrant County. Their M&O is down 14%, and the change in tax bill is a decrease of $15 on average. That is the chart on the right. The chart on the left has the actual tax bills for each county's hospital district for fiscal year 26 and then the proposed fiscal year 27. The only one that is not accurate is because of the new information we got on Dallas County, which changes it from $171 to $47. But that's the information that we could glean off the internet.
Okay, if I can just intervene here, just for everyone, for members and the public, all of those hospital districts own and operate a hospital, and we do not.
Correct.
And many of them are larger metropolitan, so their population is greater than ours. And also for University Health, they only rely 14% of their budget on property taxes, just FYI.
Majority of those have a significant amount of revenue from patient revenue, from grants, and from other sources that is significant. 80%, about 84% of our revenue comes from taxes.
So they've learned to grow their other revenues.
Yeah, you can do that with a hospital.
Okay. That's why we have the foundation.
Next slide, please.
Yeah, keep throwing that out.
Okay, this is, we're gonna move, more specifically into our budget presentation. Attachment A, our high-level budget. Again, the FY '26 approved budget and the 3 tax scenarios that we are, presenting. And that's just as a reminder, the scenarios are, no new revenue, 6% over no new revenue, and 8%. So I want to go back to what Dr. Lee was talking about. He mentioned that we're proposing a capital investment to accelerate the development of a psychiatric emergency department in inpatient psychiatric hospital beds at Seton Medical Center. As he mentioned, the amount, the amount is $20 million. We're proposing to fund that with proceeds primarily, and a letter was just passed out. There's a recent settlement related to property that's been part of an eminent domain lawsuit for a while related around the Hancock Center. We recently, just late last week, received a payment related to that. And so the $20 million reserve will be primarily funded through that settlement payment. So there's some detail on that. Sorry, that's really new breaking information.
Jeff, can you repeat that, please?
Yes, so $20 million reserve. As it relates to funding the reserve, it'll primarily be funded through the settlement proceeds of that eminent domain process that was at Hancock. So there's a letter that we passed out that gives some information related to that, the settlement of that. The settlement amount was $18.5 million. So our proposal.
So, sorry, Jeff.
Sure.
Another question came, is that to our favor or to them?
Oh, yes, sorry, it's to our favor. Yeah, I'm sorry. So it's somewhat complicated. It's at Hancock, there's a condominium association that jointly owns the common property that was taken. And so this is the Central Health portion of that settlement or of that purchase of property. It's new money, just very recent new money. Yes, so new money, yes. So our proposal around that will restrict the funds specifically for the construction cost and future operating funding gaps. We will need to bring this back to the board for approval, for consideration in the future. So this will be set aside in restricted funds, and it would be under a capital project, and we would need to bring that back to the board separately for approval once we gather more cost information related around both the construction and the operating piece. Secondly, Dr. Lee mentioned the 8% scenario, and the 8% scenario includes funding of $7.3 million for a dedicated mental health reserve. This proposed funding is intended to.
How much did you say, Jeff?
$7.3 million.
Okay.
This proposed funding is intended to provide sustain operating support for mental health crisis center for the community. And as Dr. Lee again mentioned, it's a sustainable funding source for the future. There will be more, as he mentioned, there'll be more details in our board meeting presentation coming up. But I just want to point, it's a little hard to see on the screen, maybe a little easier in the handout, but you see the changes in red that we're making to reflect the $7.3 million amount. So again, the difference between the 6 and the 8% scenario is $7.3 million. We're increasing other financing sources by $7.3 million, and we'll request a new reserve that the board would need to approve for a mental health reserve of $7.3 million that you see at the bottom of the screen in red. Yeah, thanks.
Why can't we put the mental health
Can you,
on the 6%?
so how about, let's have a discussion
Okay.
once he's done about this, because
Sorry.
I would appreciate that. So how many more slides do we have? Because we would like to have a frank,
We have a few more, so we'll
if you can,
speed up and
yeah, so we
and
can
go.
have a discussion,
So,
please.
next slide, please. So this relates to some of the expense reductions related around the no new revenue rate. All of the detail in this slide was included in the budget memo. You see $39.9 million in expense reductions, $4.4 million related around workforce, which would be salary increases that would be foregone related to that scenario. $23.7 million related around existing patient services, and then $11.8 million around service expansion delays. Next slide, please. So again, these are slides that you've seen. Attachment B doesn't have any changes. Again, this is our network and our direct care services. And, you know, related to that, a couple of the major areas are around community care. Community care has a $117.5 million budget. There's $21.4 million of other FQHC primary care in the budget. $31.3 million for integral care, which is about 73% of our behavioral health budget, and then $600,000 for the sobering centers continued operations. Next slide. This attachment hasn't changed either, other than we had a request to pull out and delineate AI or artificial intelligence expenses. And so you see that broken out both in the healthcare operations around artificial intelligence consulting, and then a little over $200,000 related around a employee benefits software system. Next slide. And this is the last piece of attachment B. Again, you see the detail on the other financing sources at the 8% rate. At the 8% rate, the $7.3 million amount is the change on this slide also. Next slide. So there's been a request to look at a few more forecast scenarios related around tax rates and how they would affect Central Health's reserves. So we've added a couple more scenarios here that are in the dashed lines. There's a table of dollar amounts up on the top So those are dollar amounts by the 5-year forecast. Again, the 8%, 6%, and no new revenue scenario are the non-dash lines, the solid lines. You've seen those before. We've also run a scenario that's in the dash line of a 6% year over year. So you see the dash line ends up at 71 days of reserves on hand at 2031, with $134 million at the end of fiscal year 31. And then a no new revenue rate year over year that depletes our reserves by 2030. And so in that scenario, of course, that wouldn't happen. We would have to make significant cuts in services in order to straighten and flatten the reserve line off on that scenario. Next slide, please. So we were planning on running a scenario, live scenario. We could come back to that at the board meeting if the chair desires to do that. A couple of other additional scenarios here related around our forecast period. The two on the left are new scenarios. There's an 8% scenario in the first 2 years and 3.5% thereafter. And then the last scenario is a 3.5% scenario year over year that by fiscal year 31 has depleted our reserves. So again, we would have to make adjustments accordingly related around that scenario. The last two on the right are ones that you've seen, a 6% year over year, and then, of course, the no new revenue scenario across all 5 years. Yeah. Next slide, please. So again, coming back to the agenda and the requested action that we'll request at the board meeting would be approval of the FY27 proposed ad valorem rate on the public notice, and then approving the public hearing time and location of the hearing. So, sorry, that was kind of a rushed presentation. I know we're pressed for time.
Thank you. Appreciate
Good
you.
job.
Thank you for all your
good
hard
job.
work. So I am gonna do a couple things. Before I take questions, I'm gonna go around the room and see where board members are in terms of the tax rate, and then we can have a discussion. So we just need to figure out where we're at. So Manager Jefferson, where are you in terms of the tax rate? Where do you, so there are 3 scenarios presented, so which one are you more in favor?
I just want to say with this new budget information, with the 7,300 and the 21 million or something like that. Under the 6% scenario, I didn't catch, what is the difference? Usually it affected the amount of reserves, but there's a shift in the amount of reserves even still,
Yep.
8%, right?
So 8%, it's the difference between 6 and 8%. And so I think what you're asking is, or I thought I heard a question, could you do it at 6%? Could you reserve $7.3 million? The answer is yes, but again, you're giving up the difference between 6 and 8%, so that would come from contingency, and you would not have that difference compounded year over year that would provide the sustainable funding. So you would have to draw that from contingency over that 5-year period. So the difference between 6 and 8% over 5 years is about $45 million. And so without that 2% compounding, you would reduce it. You would start at $45 million less, and then you would draw down your reserves even further,
But that's
depending on the extent that you funded the mental health reserve.
okay. So basically the 6 and 8 will fund the same services, but the differences will be in the reserves. If that answers your question, Manager Jefferson. So, I just want to get a feel, like, where are you, so we can have a thorough, discussion on the budget. Where are you leaning towards?
I want to think about it.
Okay.
I want to hear from others.
Thank you. Manager Kitchen?
I have a lot of questions, and so I can't say for sure. Here's what I can say. For purposes of our vote today, I'm fine with 8% because it's the maximum. And I think we should just do that and give ourselves time to think about what's being proposed to us. With regard to the difference between 6 to 8, I've been leaning towards the 6, but this is brand new information about what we might be able to use the 6 to 8 for. I'm not in favor of just putting the money in reserves, which is where we were at before today. Because to me, that's like saying to the public, we're gonna go to 8% and we're just gonna put the extra money in our savings account, without telling them what we're gonna use it for. So I'm not in favor of that. I'm intrigued with what's being proposed, but I don't have enough information yet to know whether that's sufficient for me.
That's fair. I just wanted, I think the chair and I just wanted to get an assessment where everyone falls.
Sure.
Dr. Martin?
I currently would favor the 8%, in particular for the allowance. I agree with Manager Kitchen, not just leaving the money in the bank, but the effect on mental health would be beneficial. I think we need to see ourselves we're in an incredible expansion mode at the moment. And we need to we have large sums going into capital expenditures, growing out the system. And I really think we need to do that. It's a normal expenditure at this time in the growth of a business. I discussed this earlier, as I worry as we go into an episode of borrowing money for acquisitions, that it would affect our interest rates to have diminished reserves. I think our bond rating could, I don't know that fact, but I assume it would affect the interest rates we have to pay on the debt service, so.
Okay, thank you.
Thank you.
Vice Chair May?
I'm interested in exploring the 6%. And what I mean by that is, I want us to take a look at how can we do the mental health programs that, like, most recently got introduced to us by the mayor's office within that 6%. How do we, and forgive me because I wasn't here at the last board meeting, so I don't know what this additional 21 million is, or 21,200,000.
Which line?
The line that's over here under looks like it's financing, other financing uses. What is that? And I apologize because I was not here last time. You've got it in red.
Is that
So
prepayment?
it's other financing sources. The aggregate of it is three things. So there's a transfer to our emergency reserve fund. So we're mandated to maintain a emergency reserve at 15% of recurring expenses. The second piece of it is about 912,800, something like that, for the foundation request. And then the third piece of it would be the mental health reserve that we're talking about, the $7.3
So you have it twice. You said the mental health reserve you're talking about? I thought that
No,
was.
I was just giving you a rundown of those amounts. So, it's
So 21 million.
21 million. So the three components of it, again, are the mental health reserve, the $7.3 million. There's a 12.9 million dollars transferred to the emergency reserve, and then $912,800 for the Central Health Foundation.
Okay,
That's
now
the
you've got me confused, because I thought the mental health reserve fund of that 7.3 million, down at the bottom, I thought that was for the new program that we just discussed, potentially.
It is.
Okay, but then you also mentioned it
In the
in this
21.
category that you talked about.
Yeah, so we're.
Are we double count? I don't know.
No, we're not double counting. We're moving the dollars into the reserve, and we're showing the reserve balance.
Moving it from where?
We're moving it from our contingency reserve
Okay.
to our public health reserve. It's the difference between the 6 and the 8%. That's the $7.3 million amount.
Okay, under your 8%, okay. Okay, I got it, okay.
Okay, so.
So my whole point is, I'm interested in figuring out, or not figuring out, in learning more about how we can do these programs under the 6%. And if it means that you're getting into the different reserves, then just be real, be real clear with us into what that's gonna mean. And the reason I'm suggesting that is because we are in the middle of a brand-new strategic plan. We're developing now and just beginning to put it in. That strategic plan, the hope and the goal is that we're gonna incorporate the programs that are currently under the equity plan, which we don't know exactly what that's gonna look like, but that's the whole goal, is to incorporate all that. We also are under a brand new draft of our facilities plan that we have no idea yet what that's gonna come out and look like. And what else, what other document? And then we're redoing our policies as well. So we've got some major items that are gonna impact the future of this organization. We're looking at them now, we're working on them. And so I'm not interested, from my perspective, I'm not interested in, continuing the status quo per se on that 8% as we've done last year. I am interested in funding all this new stuff, and I'm interested in seeing how we can fund that stuff under a 6% and see how does it impact our budget and our commitments? Because I think it's very wise for us to take a pause, and just take a look at where we're at. Let's take a deep breath. We got a lot of programs coming up. We've got a lot of movement coming up. There's going to be change in the future. I do anticipate we're going to be changing how we're moving forward. A good change, but not a negative change, but I do anticipate a change. And that being said, we also have in the future coming up potentially the acquisition of major facilities. Without mentioning them, I think everybody knows what I'm talking about. But all that's going to play in. And I would like for us to at least be in a more of a balanced situation where we are not borrowing money, or we're not borrowing, but we're not taxing our taxpayers any more than until we fully understand the impact of what we currently have. Further, one last point that I'm going to make. My biggest worry is next January. Are we close?
No, we're not.
Okay. So we've got a new legislature that's coming up, right? Who knows what they're going to end up doing?
So,
I want to stay under the radar.
okay. Manager Matlani,
Can I?
where are you?
Can I just ask a quick, on the analysis you're talking about, the 6%, are you wanting to look at 6% over the forecast period? Yeah.
Yes, I asked for that
okay.
last night.
Okay.
Okay.
Thank you.
Manager Matlani, where are you in terms of the tax rate? Your speaker, please.
Read my lips. 8%.
Okay.
And I'm a vehement believer in the notion of the progressive tax being one of the most powerful levers of economic mobility that we've seen. And I could leave it there, but I'll also add that we are effectively, not just us, even commercial organizations are rationing care. So whether these dollars go into a reserve or whether we apply these dollars toward needs that surely will have been unmet otherwise, it's the right thing to do. The cost of capital is predictable and acceptable. And it's a year where the taxes are going down anyway as a result of values being assessed, which means the only folks who are being affected are those who are potentially liquidating at this time. And then this chart, millions of kudos to y'all for bringing this chart. If we were to see this by income, it would look even more ridiculous, because we have no middle class. And so basically where the weight of these taxes are borne is where it should be. Thanks.
Thank you. Dr. Brinson, where are you?
8%.
Okay, thank you. Chair Rodriguez?
I don't want to bear the lead. I'm opposed to the proposed tax rate. I think there's some big trust issues. I have trust issues with this budget. When last year, this board approved the budget and this administration didn't use all of it and had a 13% that they did use the budget, and then they put it in reserves and then asked for 8%. That doesn't make any sense to me. Like, again, I think as Manager Kitchen said, putting it in a piggy bank or savings account and taking it from the taxpayers because we don't trust going to the taxpayers with a tax ratification election. I'd rather go to the taxpayers. Here's the other piece. In terms of reserves, and y'all can fact check me, I think we have more reserves that are contingent reserves than the city and the county combined together. And if I don't count, I'm not a big fan of line item reserves, which we use. I know the county uses it. I don't know if the city uses it as well, but I'm not a big fan of that because what it does is it constrains this current board from any crisis that you have to do because we've been locked in by all the other boards. And by the way, the law allows us to go back and reconsider all those line item reserves. So it's not like we can't use them in case there's a real true emergency. I like Manager May would support what I've already said, which is a moratorium so that our strategic plan, our facilities plan, our CHNA catch up to us and align to the resources and the outcomes and the impact that we want. And the last thing I'll just say about this is that I really believe in living within our means. And I support balanced budgets. I support a no new revenue, which still gets you $19.8 million. I can support an additional increase in this tax rate, whether it's 4, 5, 6%, as long as we're showing value to our taxpayers. I've been here for decades as a taxpayer, and one of the things that I would love to see is how we're adding value with what other additional dollars we're doing. Because, for example, I misunderstood, I think, Dr. Lee, the proposal you were making, because I was thinking you were going to propose 6% and all of that goes into the mental health fund for operations for whatever it is that we want. Mental health crisis center, psychiatric bed facility, brain health, whatever all that is, I would be in favor of that because I think that shows taxpayers that we are committed to moving forward with our responsibility to take care of hospital and healthcare services, which is the statutory language about our obligation here. So, and I didn't even mention, in addition to the strategic plan, the facilities plan, the CHNA, and an updated mission, vision, and values, because at the end of the day, a budget is a moral document. And if we're not going to spend it all, then why are we approving it? Because that's our job, is to approve it. It's the job of the administration to spend it. So I'm just trying to wrap myself around, like, well, if you had 13% less, you could use all of that to fund everything that community care is asking for. You could fund part of what Sendero is asking for, and you could continue all your services. So there's nothing that's like a cliff on all those options that you have. And so to me, we need to have honest conversations about this. And that to me is really, really important, especially in the environment that we're in. I do not want to be tone deaf to all the affordability and challenges that our taxpayers are facing. And so if we're going to increase taxes, we should be showing value for that. And I will stop there because I think I really appreciate Manager Mercedes, you asking us about what our perspective is, because I think it's important that our administration understands kind of where we're at and what we're going to be doing this next year.
Can I present my position?
Sure, go right ahead.
I heard really.
Go right ahead.
I have been contemplating so I think during budget season, I don't really sleep well. I have a really difficult time because there's a lot of weight on it and ensuring that we are fulfilling the needs of our patients in our community. So it's a really difficult decision for me per se. With that, I have did my own research, simple trying to assess the scan environments, what other hospital districts are doing. I know we can't compare apples to, oranges here. They're different, but I just wanted to get an assessment and feel where other hospital districts are. Many who elected not to increase their tax rates, but that doesn't mean that we cannot continue on with our services. And also, there is an opportunity when we pause and reassess. Giving what we just heard today from the vice chair and the chair, what's coming down the road, what's happening right now. We're in the process of updating our strategic plan. We're in the update, facility plan. There's a lot happening that we are right now basing our budget on some previous decisions that we, the board, decided to move forward. But we are in a different era, in a different position than where we were 5 years ago, per se. That also means that I definitely, support our mental health, because it is, when we talk about health and what it is for for our population. So with that, I looked at the comparison between the 6 and 8, what it offers. It really does not change if any of our, the service deliveries that we have before us. So with that, I am not in favor of the higher increase of the tax rate per se, given with information that I have. That doesn't mean that I'm not supportive of all the other initiatives that we have before us. We can figure out a way. We have our reserves. We can think about innovative way and think about the environment where we're at today. I know we may have the capability of increasing, but what benefit does it bring? And sometimes efficiency is the key. And thinking about, really, I encourage us all to think outside of the box, to pause, to reassess where we're at, and ensure that we are providing the best, highest quality of care for all those who need it. So that's my position. Manager Kitchen, you had something to say.
I just wanted to add to what I said before. The staff's been great in helping me understand what we're doing for mental health, but I still have additional questions, and I'm not yet to the place where I think we're doing enough. So I'm gonna want tonight. I heard what you said, Dr. Lee, but I couldn't process it. It was too fast. Plus, I need it in writing. I want to make sure that we are addressing all of the 6 bullets that the mayor brought forward for us. And I want to address those without taking funding away from other mental health services that we're providing. And I want to make sure that we are covering the asks that are in front of us from the other mental health services. And I'm not yet satisfied because I don't have all the information yet, although you guys are giving us information, but I have more questions about what we're doing with regard to integral care. You guys heard this morning, we had someone speak to us about the HR aspect, the
merit increase.
The increases. And, we have built increases into our staffing for CUC, but I haven't yet heard that we have changed our rate to integral care, or other partners for that matter, to address those kinds of needs in the community of our lowest wage workers. So I need more information about what we're doing about that. So anyway, so that's kind of where I'm at.
Thank you.
Thank you.
Thank you for that. I think just to follow up, and I will come to you, Manager Jefferson, I think from a board's perspective, it would be very helpful to have a portfolio of all the mental health services that we're providing, and the amounts. Like, I personally, I get lost. We're investing here and there. What is the big picture? And I think we're building something. It needs to be a coordinated effort with all the partners who are doing this work, but also we need to be very intentional and mindful in really filling in that need. So from a board's perspective, I think it would be, I think from what I heard from Manager Kitchen and others previously, we want to have a full better picture and understanding of all the mental health services that under that umbrella, and how much and what we're funding. If it's okay, if I could take Manager Jefferson, and I'll get to you. Manager Jefferson.
So, like you, Manager Messiah, I've been thinking about, the gravity of this decision as to where I'm leaning in all of this. And I come down to making sure we have flexibility and options. This draft budget has been changing as we speak. And so I think I'm moving toward allowing for flexibility. And that means putting the notice at the 8% maximum rate. This is a step in the process. The process is going to be a public hearing. There's going to be more debate. We're going to get more information. Now, I will say the reason why I've been torn and was reluctant to go first, I still struggle with what is the difference really between the 6% and the 8% other than the reserves. I feel like based on my review on the Central Health activities in the past year, we have the great intentions of moving post haste with things, but it doesn't move that fast. So does it really have to be 8% for FY27? And I don't have the answer. I don't feel like I still have the answer to that, but I want to have the flexibility to, when it's time to ultimately vote on the budget, I want to have the flexibility to go to 8% if I feel I am informed and feel that number is supported.
Okay, thank you for that. Yes, Dr. Bernstein?
What the mayor is proposing is going to cost a lot of money, millions of dollars. Last year, we funded Integral Care for $90 million, and when we agreed to do it, at least that's what the computer says, and when we agreed, we said 70 million, and then in a very short period of time, it apparently, according to this, went up. And that's not all that we fund. You know, we fund the community care, behavioral health. We fund, I don't know who pays for the addiction facilities that we send our jail patients to, but since they're all in Austin, I have to wonder if we aren't putting a fair amount of money into that. The mental health in this community, it's an endless supply of money. I don't think that we should be, at this point in time, when the mayor is just starting this, that we should spend our time now, when Austin is still an extremely rich community, and most of the burden of the taxes lays on the people who are making more money, you know, $1 million or $600,000 a year in their homes. I think things are going to get worse. That's what I think. I think things are going to get worse. And when they get worse, what do you think the taxpayers are going to say then? And do I mind that we're putting $7,300,000, in the bank to make some interest on it? No, because the mayor is going to make us spend that money in a fairly short period of time. So I would say that when things get worse, we can talk about cutting the amount. But right now, I feel like we're still living pretty high on the hog. So that's just my opinion.
Here, here.
Okay, thank you. I have a clarifying question. Jeff, how much are we funding Integral Care at this moment in time?
Our proposal is $31.3 million. We're funding them in 2026. It's about 30.9 million, I believe. Is the amount.
39 million?
30.9.
Okay.
30,
it's
so
a
it's not
$400,000
It's not the
increase.
It's not 70 or 90.
I think you're taking the CUC number.
Okay,
Yeah,
thank
let's-
you for
let's-
that. So,
I mean,
okay,
can-
just to
can-
move forward with our conversation,
Can I say something?
yes, Manager
Um,
Kitchen.
There's no I do think it's important to be accurate about the number for Integral Care, because it's 30, not 70 or 90. But that's not the point. The point is, mental health services do cost a lot of money. And I also, the way I think about it is, we're not funding Integral Care. We are paying for mental health services for our patients. So, and mental health services are very expensive. I agree with Ms. Manager Brinson that it's a large amount of money, but it's also the source of many of the problems in our community and many of the problems that our patients have. I think that the mayor nailed it in several ways in terms of talking about the needs of this part of our patient population, and they are costing a huge amount, and it's just a cycle. We all know that. So when I say that, what I want to know is what would it cost to do the kinds of things that the mayor is asking, because they're all important, and we need to understand what it would cost. I feel comfortable that the services that we're funding right now for our patients are all needed. And so the funds that are going to integral care are paying for services that our patients need. So we just need, like Manager Musaitis said, we need to all understand it, you know, and then we'll have to confront what Manager Brinson brought. You know, it's expensive, and how far can we go?
I have a question for Manager Kitchen. So in terms of right now, we're having this conversation around this mental health aspect and the mayor's proposal.
Yeah.
So what would you amend the budget, like some kind of direction? I think they need
Well,
the staff.
I need to understand the cost of these items. I can't tell yet how much we can afford, and because I don't know, some of these things I think we're already paying for. And so I need information about what the cost would be for these things.
And Manager, when we do the mental health funding services in the Board of Managers meeting, you'll
Okay.
get some of that detail.
We'll get some of it,
Yeah,
okay.
I don't know that you'll get everything, but at least it'll be a start.
Okay.
You'll get that tonight.
Yeah, I want to know, and I'm also curious, others brought up, how much of this is already in our budget? How much is in the 6% versus 8%?
Okay, thank you. Dr. Martin?
I'd just like to make a note with the mayor's letter that, you know, our responsibility is healthcare. And mental illness, et cetera, is intricately tied to homelessness, to other things. And where are they picking up that piece of the puzzle? Our job is to provide healthcare. They have to also to lay this at our feet and say, I want this. Great, build me 1,000 houses. I mean, it's fantastical thinking, I believe, to sort of base this. Here, I make this demand on you. We're trying to do what we can, but our obligation is to healthcare. Their obligation is to other issues related that are completely wraparound facilities. But I don't think we can just ignore that and say, yeah, well, we'll do this because you said so. Well, great, I'll do this. You build me 1,000 houses. You know, I mean, it's whimsical thinking, I believe.
Okay.
And I
Thank
think
you.
but I think it's whimsical
Dr.
thinking.
Brinson?
Well, I think it's whimsical thinking to think that this is not going to happen because having dealt with the mayor in the past, I don't think he's going to back off of this. I think she's right. And you read the letter, and it said, if you don't support this, I'm not supporting anything you guys want out of taxes, so you're going to get nothing. And I just think we have to be accepting. Do I think it's all going to work out? No, I don't, actually, because I think it's an endless supply of money. But if you're looking at somebody on the street who's psychotic and potentially dangerous, and you're looking at somebody who's having a heart attack, sure, the heart attack is happening right this minute, and the guy on the street hasn't slit somebody's throat yet, but that'll happen. And then we'll end up paying for them repairing the guy he slit his throat. I mean, I have seen it all at the jail, and I just think that we would be foolish to not see if we can get the full extent, because there's a lot going on in this town, and people are going to be asking for a lot of money.
And I'm for spending money on mental health services. My point is to write a letter back and say, great, we're doing our part. What are you doing?
But you
Okay,
know,
okay,
it's-
okay.
Anyway, so-
I'm gonna take back this conversation. Dr. Manager Motwani.
And I still have my hand up, but
Okay.
make sure I get
I just want to say that, you know, I've heard, I know nobody's like resolutely against something or you know, so I wanted to make sure that it's clear my comments aren't addressed to any of our colleagues here. But to kind of everyone's point, the issues that we're facing, it's a watershed moment. it's in my lifetime never seen it like this, and I think it hasn't been like this since Reagan days, or at least this big of a change. In as much as homelessness or folks experiencing homelessness being a public health and safety and moral and justice issue. And I think that any elected official or administrator or governance person who does not leverage every resource available to them to help collectively solve this problem is going to be looked back at as a fool. And whether that's a politician who doesn't play, or whether it's someone like us. And so I just want to say that now and on the record. So thanks.
Thank you, Manager May.
Thank you. I just want to reiterate, first of all, I absolutely agree with everybody's points here because I think everybody's on the same page. We all understand that this mental health problem is literally outside our doorsteps. Every time I get in my car, from my house to drive to the next corner light, there's something going on that is screaming at me saying mental health, mental health. So it's obvious that we've got a problem. I'm not suggesting, I want to make it very clear, I am not suggesting that we do not fund any of these proposals with respect to mental health because I do understand the importance of it. And I understand the importance of it from a public health perspective, from a public safety perspective, and as a stewardship perspective. All I am asking, or all I am trying to understand from my end, is for us to seriously, and I do hope to see, you said you're going to submit a forecast budget at 6%. And that's what I want to see, because I'm very serious about us adjusting, looking at where we can adjust ourselves if necessary with what we're spending and where we're spending it. Is it in the right categories? Are we being efficient with our dollars? I don't know. I mean, perhaps we are, perhaps we're not. But I just think it's a nice it would be a good moment for us to step back and take a look at kind of where we're at. As it was suggested earlier, 7 million is not a whole lot of money, but it does give us an opportunity to pause and see where it is we want to go with respect to some of our other priorities that they're coming online. We've got 2 more retreats coming, as you all know, for strategic planning. We don't know where our priorities are going to land. So anyway, I just wanted to say, I think mental health is very important. I believe that it can be done on a 6%. We can fulfill everybody's needs at 6%. And if you needed to go into our reserves, we can go on reserves. We can agree to do that. We just sort of, as a consensus, sort of thought we should do that tonight for something else. So I'm just putting that out. It's not an impossible need to do.
Okay, so what I am hearing from the board, just to make sure that we all understood, that for the proposed tax rate, you want to allow some flexibility to allow us to go to the 8%, but there's a lot of hesitation for the long run for our final vote to go to that percentage. And also I heard that we should fund mental health and have a portfolio of what services that we are currently providing for the board to understand what we're doing and actually how much we're investing, and also thinking about the return. And it's not just the outcomes that we're presenting, that it's coming out of our investment. And also I heard from a couple board members, and perhaps I also mentioned it, an interest perhaps to pause on some of our some of our initiatives that are in our current health equity plan.
Haven't been started.
That haven't been started. So I just want to see if that's a consensus around that staff can go back and readjust their budget. Perhaps we can maneuver around the 6% per se and ensure that we're continuing on the current services, fulfilling our commitments, and perhaps if we need to dig further in our reserves, we have that. So am I hearing you all correctly? I just want to make sure that, or did I miss anything?
I think you got the big picture. Various of us mentioned other things that we'd like the staff to do, but I think you've got the big picture.
I will get to you, Monica, 1 second. So are you all fine with pausing with the current, new services that part of the health equity plan for this upcoming, for fiscal year 27?
I am open to conversation about that. I can't say without seeing what we're talking
Okay,
about and
so
how
a
much money.
conversation, I think having a conversation chair, if you can have it as you move forward and with your conversations with our CEO, come back to us with a revised budget that perhaps with an option, if we can pause on certain service lines until we have all our, I think, all our
Good
pieces
understanding.
aligned, or, so I think that that will help us to move forward. So with that, Monica, you had a comment?
Yeah, I don't have a comment, I do have a comment. We're gonna be passing out right now the No Wrong Door,
Okay.
our response, the draft response to No Wrong Door, plus the, presentation that's gonna be on the Mental Health Crisis Center that was emailed to y'all but didn't get printed
But isn't
out
that for the next-
in the packet. So that's in the board meeting, but just so you know, for we have two of the things, and then also in your packet right now is a printed out list of all of the fiscal year 27, every mental health investment. So in asking the mental health, all of the mental health investments is already in your packet. It's one of the printouts, I'm not sure what line it's on, and then the No Wrong Door draft response is just
Okay.
being handed out now as the printed out presentation.
And then I had
Yeah.
that one
Yes.
additional question, but I don't expect y'all to answer it tonight.
Oh, on the
On,
integral care?
on what we're doing is not just for integral care, it's anybody else, because we pay for services from other people too. What do we do with our rates with regard to recognizing that we're recognizing cost of living increases?
So, okay, so they may not be able to,
No, they can't answer that tonight, but.
no, so that is something that will come back?
Yeah.
So right now,
Research time.
is it clear our next steps forward? I just want to make sure that you understood, Jeff and the team.
Could I ask if there's any specific guidance from the board on, are there particular services that you would like us to consider for not pursuing or pausing going into fiscal year 27?
Yeah, exactly. So that's a decision that on your behalf, that what your recommendation forward. So I think we're concerned more of new services that are not in line, like you don't have them live. So maybe not the current services that you have. I don't want to stop a service that you have in existence, but new services that you were planning for the upcoming
Next
fiscal.
new budget.
So we have services planned for new facilities like the Hancock Center, specialty care services, the dental suite, the.
So those are-
The imaging services, are
So
those
you
the
guys have
kinds of
to
services?
make those best decisions, inform us of what those are when you come back in, so that of course we know what it is that's being impacted. That's why I want that forecasted, I think a forecasted budget with the within the context of that 6% would be helpful to us, so we could get a better understanding. And also, if I may just say with respect, it's a very good question, absolutely, John. But one more point, nobody knows where you are in those, in terms of the timeframe and in terms of the phases. Nobody knows that better than where you're at. So that's why you'd have to be the ones to be making those best decisions.
Understood.
So is that clear?
We can come back with recommendation of
So that's
services
what
that
we're
we would
asking
not
for.
pursue.
Yes.
Okay, sounds good. So with that, I think we are concluding.
Can I make a
Yes,
15-second comment? I just want to get back to our budgeting process.
Yes.
So we do a fiscal year 26 estimate, and we use that estimate to roll into our 27 forecast. So this year, we're not proposing an 8% rate, and any unspent falls to the bottom line. We've included the impact of that in our beginning balance. So I just want to point that out as a process.
Thank you, Jeff. Much appreciated. And I think we will have a little further discussion around the mental health continuum. But also, another last question for board members. In the budget, there's a 7.3 allocation. want to keep it as is for the time being, or we can have further conversation? So any further direction to to staff?
I need to understand this better.
Okay, so let's leave it at it as is right now, and then we'll come back to it. Thank you all, appreciate it, and with this, I am gonna conclude our meeting. Do I have to announce our public hearing? Okay, perfect. So, agenda item 9, confirm the next Budget and Finance Committee meeting date, time, and location. Managers, our next Central Health Budget and Finance Committee is tentatively scheduled for Wednesday, September 9, 2026 at 4 p.m. at the Central Health Headquarters, 1111 East Cesar Chavez, Austin, Texas, 78702. At this time, I'm ready to accept a motion for adjournment. The chair moves.
Second.
I have a second. All in favor? Aye. We're adjourned.
I'm gonna go to the ladies' room real quick. You can get started, right?
Bathroom break and then we'll start in
Okay.
5 minutes.
Okay. Well, you got right through it. Thank you. Good job. That was not easy. Good job.
Anyway, that's right. So it's just makes us, that's right. Carryover number's not gonna change as much, That's right.
Excuse me, ladies.
Yes.
I just want to talk to you, well, not now, but about the mental health stuff.
Yes,
In
I
terms
mean,
of what all is in there.
Okay, I'm
Yes.
not, there's some problems.
Yeah.
Oh, that's okay, how are you? I haven't seen you in a while, but. Well, I, wanted to come here and meet our. Especially the professor and you came in. I'm sorry, I didn't interrupt. Oh, that's okay. I have questions for you after y'all. Great. I'm dying to work.
Yes, there's so much, I know we have like very little time to talk. I think for us, like what you were saying as well, sitting and go listen, is one election, we're on that house now. So,
Yeah, we're gonna
that's
need more
the
than that.
You ready? Good evening. Today is July 29, 2026, and it is 8:41 p.m. As a quorum of the board is in attendance, I'd like to call to order the meeting of the Central Health Board of Managers. And as a reminder, some of our board members may be also participating by video conference, so the staff will be managing video and audio feeds of all participants closely to make sure we have a legally compliant meeting at all times. So we had public communication in our Budget and Finance Committee, and I believe there is no one, I just want to confirm, there's no one here for public communication. So no? Okay. So I'm going to move us to the next item, which is, members, the consent agenda. If I could have a motion to approve the consent agenda item for items C1 through C3. Okay.
Second.
So having a motion for the board to approve consent agenda items C1 through C3, all those in favor, please raise your hand. The motion passes unanimously. So we're now going to proceed to the regular agenda. The first item is to receive and discuss a report from the board chair. I'm gonna be, I have 4 items real quick. One is welcome back from the August break. I know we had another meeting I was not at, but I hope that you had a good summer. 2, just as a reminder, to us as a board and to the community, we have a strategic planning retreat on Saturday, September 19th from, is it 8 a.m. to 4 p.m. or 9 a.m. to 4 p.m. And then third, if we do everything on our agenda item, members, we will be here till about midnight. We're not going to do that. We're going to try to get out of here by 10:30. As I look up to the clock. But I do want to mention, if you're following along on the agenda, agenda items 7, 8, and 9 are here just so that I can have an opportunity to just tell you that you do have a copy of the recommended bylaw amendments and the recommended procurement and purchasing policy changes. Ray Bonilla is on vacation, so he won't be here today, but I wanted to make sure that you all received that and had an opportunity. And if you do have any feedback, please reach out to Ray Bonilla and let him know, and he can have that conversation. Item 9 is also related because of some of the policy issues, and our outside counsel has been working with Nakia on that. And Nakia, thank you for working with him, trying to make sure that there's alignment and harmonization between the work that Nakia is doing and this other work as well. With that said, I'm going to move us to item number 2, unless there's any questions. Manager Mercedes.
No, it's really more of a comment. Board members, I will not be at the retreat. I did give my input to Karma, so just FYI on that. And also in terms of the redlining of the bylaws, I fully support it. Just making sure if we had a conversation, or if we're going to have a discussion, if you need any feedback. If I am not present at the meeting, just wanted to document that I am support of the red lines. Thank you.
Thank you. Members, any other questions, comments? Then I'm going to move us to item number 2, receive and discuss a report from the President and CEO. Dr. Lee?
Thank you, Chair. And in the interest of time, members, there is a full list of updates in your backup. I'm just going to lift up a few of them to keep my report shorter. I'm happy to take any questions at the end of that. So the first I want to discuss is actually long-acting buprenorphine injections. So these are now live for the clinicians in the audience and around the table. This is a really transformational and life-saving treatment that's very expensive also. And so the fact that we can offer it to our patients is going to make a big difference for the long-term care of addiction and will save lives. So that's one. The second is that we celebrated 1 year of operations and medical respite, and we served 93 participants in total. And many of those individuals have moved their way through to the housing that's right for them and the care that's right for them with a continuous care journey through their entire first year. As you recall, that was our operational goal on behalf of the public. So I'm delighted to report that it is working and we're getting better. The third point relates to that, which is that we have begun the process for designing the Cameron Road Center. We are using the lessons that we have learned from the medical respite operations, including incorporating patients at the table from the design stage forward. So 2 of our patients, including the very first respite patient that we cared for, were at the table with us, providing some common sense, but totally insightful design elements based on their experience living for weeks to months in our medical respite that we will incorporate in the future design for Cameron Road. It's a deeper point that the chair and I spoke to at an earlier roundtable earlier today around patient-driven value and the importance for kind of walking the line, understanding patient experience, but also designing side by side with patients from the get-go. Point number 3 is that our Medicaid enrollment application was approved for Central Health. So that is very important toward the goal of non-tax revenue and being able to receive a range of payer sources on the Central Health specialty practice side. The fourth I'll lift up is that we passed a major milestone in system integration. As the board may recall, we had laid out 20 major areas that we wanted to bring together, essentially challenging if we do the same type of service in 2 or 3 different ways across the system, is there a legal reason why that is necessary? Let's say TDI's, versus HR versus HRSA's administration, in which case let's certainly do that. But if not, let's bring these services together on behalf of the public. And our goal for the year was to clear at least 10 of these major 20 areas, and we did that in the early part of August. So we're delighted with that. We'll keep on going. And then finally, as you all are likely aware, we are actually rolling out a coordinated effort to increase the awareness of our public of what we do at Central Health, what we can offer, and the benefit of that. And so you may have seen this coming out on local news networks, also on large billboards, our largest sort of media billboard spend, to really make sure the public has a sense of what we do and the value thereof. So those are just a few updates that I want to lift up from the fuller set that's in your backup. I'm happy to open for any questions that you may have.
Thank you, Dr. Lee. Members, any questions? Sure.
It will that be administered at clinic or the Sublocade? That's the injection for the addiction, you guys.
Dr. Shalsha, do you want to address a specific question? Yep.
Good evening, board members. Sorry, Dr. Martin, I didn't hear the question.
Where would the Sublocade be administered, at clinic? Or
It's
in the
within our bridge clinic and within the WAM, so kind of our MAT environment.
Okay. Super, thank you.
Sure.
Members, any other questions? If not, I was remiss in one other announcement under the board chair, so I'm gonna just talk really briefly, because Nakia has agreed not to present tonight, so which we really appreciate. But one of the things that we were gonna bring up is that we have recently learned that the Texas Department of Information Resources annual cybersecurity awareness training requirement applies not only to employees, but now also to elected and appointed officials. They have a deadline of August 31st, so you'll see an email around that. And I think I've done some cybersecurity training before. It's probably, what, 30 minutes or an hour?
It's 30
30 minutes,
minutes.
yeah. Yeah,
And I made it pretty seamless for you. I'll just email you a link to the videos.
yeah,
Okay.
yeah.
Has that been sent out already?
No, it's going to. So I just want to make sure that you saw the email. It'll be from Nakia. Not, I was going to say it not like Netflix, but it's 2 videos, 30 minutes. And if you could do that by August 31st, that would be
Better than Netflix.
Appreciate
It's
it.
just going to be prime entertainment.
Yeah. Members, I'm going to move to item number 3, which is to receive and ratify Central Health investments for July 2026. Can I have a motion to ratify? Second by Manager Matwani. So the board has moved to ratify the Central Health investments for July 2026. All those in favor, please raise your hand. 1, 2, 3, 4, 5. All those opposed? All those abstaining. So we have 5 members saying yes, 0 no, and 3 abstaining, and that's Manager Jefferson, Manager Kitchen, and Manager Musaidif. Manager, I'm gonna move to item number 4, discuss the fiscal year 2027 central health budget. We added this just in case we needed more time, but I think we kind of walked through everything we needed to in the previous meeting. So unless anyone has any burning questions, we're gonna move on from item number 4. So I'm gonna move us to item number 5, discuss and take appropriate action on Central Health's proposed property tax rate for fiscal year 2027. And I think, Jeff, are you all presenting? Or are we doing a motion?
I'm prepared to make a motion.
Okay, unless there's any questions for staff, we will take a motion, and I recognize Manager Kitchen.
Okay, I move. I move that, this is item number 5, right?
Yes.
I move that the board approve a proposed total property tax rate of 0.135195 cents per $100 of taxable property value for the 2026 tax year, which will support Central Health's fiscal year 2027 budget. I'd like to add that I'm doing that because we're just setting the maximum rate now, and this is not final.
Thank you. Is there a second?
I'll second.
Manager Matwani seconds. So we have a motion by Manager Kitchen, seconded by Manager Matwani. Ms. Brianna Harris will now assist me in taking a roll call vote. This is a requirement to take a roll call vote. So for the roll call vote, Ms. Harris will call the name of each board member in attendance in alphabetical order. Each board member must indicate whether they are voting yea or nay or abstaining from a vote on the proposed tax rate. Ms. Harris will confirm your vote before moving on to the next member to ensure we have an accurate vote tally.
And Chair, just before that vote, in this discussion portion, may I add a statement?
Sure. And I apologize. Yeah, we should open it to discussion. So we have a motion and a second and any discussion, and I'll recognize.
Thank you.
Manager
And
Mahoney.
the statement is just that to the effect of what Manager Kitchen shared. I think it's our responsibility to at least look at the most flexible option.
Yeah.
And this does not bind us in any way in the future to remain
Right.
with that.
That's
tax
right.
rate.
That's right.
Oh, sorry, your mic.
Do I have to repeat it? Okay.
Yeah,
My answer.
So, to Manager Kitchen and, its comments, again, just to clarify, this is the maximum amount proposed by the administration so that we can have a public hearing. Okay, and so, I think given the comments I made before, I mean, I support the will of the board and having a discussion, but I think the comments that we had in the previous session hopefully will show that that this board is engaged and that this board is owning this process in the budget. And so I'll be supporting the proposal to have the public hearing, but I think all the other comments stand that everybody made, so. So Brianna, you ready?
Okay, I'm just gonna go left to right. Manager Amit Matwani.
Yes.
Manager Amit Matwani votes yes. Manager Cynthia Brinson.
Yes.
Manager Cynthia Brinson votes yes. Chair Jeronimo Rodriguez.
I'm gonna abstain.
Chair Jeronimo Rodriguez abstains. Treasurer Maram Musaitif.
I'm abstaining.
Treasurer Maram Musaitif abstains. Vice Chair Elisa May.
I really want to vote differently, but we're just doing a public hearing, so I'm going to go with the public hearing, so can you forward on the public hearing? Yes.
As well.
Vice Chair Elisa May votes yes. Secretary Manuel Martin.
Yes.
Secretary Manuel Martin votes yes. Manager Ann Kitchen.
Yes.
Manager Ann Kitchen votes yes. Manager Sadora Jefferson.
Yes.
Manager Sadora Jefferson votes yes.
Great, thank you. So we have a majority that passed. 1, 2, 3, 4, 5, 6 yeses and 2 abstentions. I'm gonna move to item number 6, set the date, time, and location for the public hearing at which the Central Health Board of Managers will present and receive comments from the public on the proposed fiscal year 2027 budget. Do I have a motion? Manager Jefferson.
I move that the public hearing on the proposed maximum tax rate be held on Wednesday, September 2 at 5:30 PM at Central Health's Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702. A notice for which will be posted on the Central Health website and published in the Austin American Statesman.
Do I have a second? Manager Kitchen seconds. And then David, just a legal question here. So this does not require a roll call vote. I can just ask for it. Okay. So managers, any discussion? If there's no discussion, all those in favor, please raise your hand. All those abstaining? All those opposed? Did you? Okay, so 1, 2, 3, 4, 1, 2, 3, 4, 5, 6, 7 yes, and showing Manager Musaidov abstaining from that vote. Okay, so we're gonna move, managers, we're gonna move on. As I mentioned, 7, 8, and 9 will be put on another, well, actually, those 3 will be put on the next executive committee session for our discernment. Item number 10 will also be moved to the next meeting, although I will just say that there is a report from the Chief Compliance Officer regarding a pending investigation that we will do in closed session. So I'm gonna move to item 11, which is to receive, discuss, and take appropriate action regarding an updated expansion of the mental health continuum of care and associated partnerships. And Sydney Harris, Monica Crowley will be presenting. And members, while they're doing that, you also, one of the items you were handed was the No Wrong Door funding realignment opportunities. I just want to make sure, I know that you're probably going to talk about this particular part. And then you have the handout that they handed us called the Mental Health Continuum. Item 11.
That's right.
All right. Good evening, managers, chair, vice chair. Thank you for your time this evening and the opportunity to speak. Thank you to the audience and the public who has been waiting to hear this presentation, so we appreciate your late evening with us. I'm Sydney Harris. I'm the Senior Consultant of Health Systems Design at Central Health. And I have Monica with me.
Monica Crowley.
All right, thank you. Tonight we're going to go over where we have gone through in our research the need in mental health for Travis County, our progress update, the proposed mental health continuum, and our estimated costs that we have with you tonight to share with you. So I'd like to start off just reminding everyone where the crisis mental health continuum is at. This is the crisis care continuum. This is not unique to Travis County. I've shared that with you before. Many individuals are entering into their mental health care, either in the emergency department for their first time or with an engagement with a law enforcement. So what we're really trying to focus on tonight and with the mental health crisis continuum is the exclamation point that you see where many individuals are engaging with their care. Next slide, please. Our research looked at the bed benchmarks There are several varying beds that provide care for individuals within the mental health system and care providers that are at those bedsides. It's not actually just beds, it could also be chairs or recliners. What we learned in our research is that the largest gap that we have in Travis County is on the left-hand side. That's your crisis stabilization and your observation. You can see on the right-hand side, there are several not at the scale need, inpatient beds, and there's also several sobering. As I always say when we talk about sobering, many of those chairs and beds are for individuals that have a payer source or have the means to pay for that care out of their own pocket. So, what we're here to talk with you tonight is the proposed mental health continuum. This new addition, what we're sharing with you this evening, is that partial hospital expansion. That piece ties directly into the left-hand side of the graph that we were just looking at, the dashboard that shows the very much need of crisis stabilization, psychiatric emergency department, and also inpatient care. We're looking at 10 beds and an increase of psychiatric emergency and 22 psychiatric inpatient. That directly helps our partners in our community, what we've already spoken about tonight. Those are our county, our sheriffs, who see our individuals in the jail cells at a significant rate, and our APD officers who are working effortlessly on the No Wrong Door initiative that our city has been leading. This partial hospitalization expansion will make a significant impact to the full continuum, which we'll go into more detail as we explain more on the Mental Health Crisis Center. So a progress update of where we're at and what we've learned. We have reached out to our peer hospital district sisters throughout the state of Texas. A majority of them already have hospital-based psychiatric emergency departments that they are operating. They also partner with not just their local mental health authorities, but several other mental health providers in their community to fill the gap for the mental health care. And we've heard it, not to sound like a broken record, but it is a need. We've expressed that, I think, every one of you at some form of who you might have seen today walking down the street or on your way to this meeting. So we all know this is a large need in our community. We've engaged with best practice researchers that include our Blue Cottage and the facility in at Salt Lake City, the Huntsman facility. Our current focus, we are looking at financial modeling. We've engaged Huron, and we are also looking at a return on investment. Mental health is not cheap. It's actually very expensive. We've heard that again tonight as well. And so when we are investing in our community and brain health, which is healthcare, how are we getting a return on investment for our community members that we're supporting? We continue to have strong conversations with our partners. That includes Integral Care, Del Seton Psychiatric Department, Del Medical School, Travis County Commissioners Court, City of Austin, and of course, we are preparing for the legislative session that comes up in January as it ties to No Wrong Door. In September, we have the commissioners vote on our fiscal year 27 budget. We have a Central Health Board strategic planning session, retreat, and the City of Austin. We have an upcoming meeting to continue the discussion on Austin Health Southland. If we go to the next slide, I'd like to show what a mental health crisis center can look like. It is a hospital. It's a place dedicated for mental health care for the most vulnerable population and for everyone that is experiencing a mental health illness. When we toured the Huntsman Center, we heard from stories of individuals where the university students, they just broke up with their boyfriend or girlfriend. They have come to this center for a couple of hours to get relief in the crisis moment that they're in, that is a crisis to themselves. We have heard from family members that have driven their family to this facility, not even in Utah, but from out of state, go and visit this place. And we have seen and worked with the law enforcement to understand how they utilize this facility so that they're taking individuals that are in their most vulnerable state, possibly living on the street, to get them to the care that they need in a facility that has respect and dignity. This is the Mental Health Crisis Care Center that we envision for Travis County and Austin, Texas. It has many of the things that we've learned through our sister hospital districts, many of the things we've learned from other diversion centers, other No Wrong Door programs, other deflection programs, and of course, other psychiatric hospitals. What you see here is we have a one-stop shop for individuals to come in and receive the care they need, whether it's themselves reporting in, a support system referring them, EMS, an officer, MCOT, No Wrong Door, or diverted directly from the central booking that Travis County is currently working on and planning. We have observation, so if you need to stay longer than 24 hours, you can extend your stay. Mental health requires a longer runway than some healthcare. You have inpatient if you need to go in and be admitted to a longer term stay, almost similar to an ICU. Your care needs longer term. Sobering and detox, I want to highlight everything that we've heard from other centers. They did not include this in their center, and so it is a must for our community to consider because it's something from a lessons learned. If we get to build after others, let's build the right way. Crisis respite program, again, that longer term runway to recovery. You can stay between 14 to 90 days. And then also an intensive outpatient program for when an individual is ready to continue their care, moving towards recovery. And then our wraparound services, other care for integrated care, primary care, brain health, mental health, health care, it's all for the single person. Dental care, legal services, again, individuals are coming in possibly through the legal and justice system. How do we help them? Employment benefits, social services, peer services, and more. As we look in the future, we want to see a sequential adoption for continued and scaled step-down residential. We have talked about this before, and again, broken record, mental health needs a longer runway to receive care and get back into eventually the community, their loved ones, and back with their family. What we have within the Mental Health Crisis Center, these are the beds we're looking towards. It is a population for youth and for adult. We're looking at inpatient, 48 adult, 12 youth. The psychiatric emergency, which is kind of like your bay, where you go in immediately for urgent care. Emergent care is 40 adult, 6 youth. Observation, 16 adult, 0 youth. Sobering and detox, 40 recliners, 20 single rooms, and respite care, 16 rooms. The estimated project cost is between $150 million and $220 million. We have potentially secured roughly $96 million from partners within the community, and we have a potential funding grant of of $54 million to $124 million. Although, yes, and at this time, Central Health has not been asked to contribute within the construction or the project cost of that build. If we go to the next slide, these are the operation considerations. Annual operations, which totals to $43.3 million. As we've been discussing our budget this evening, Central Health, we can close the gap. In our research, we have determined that we can close the funding gap that it will take to sustain this operations of the Mental Health Crisis Center. And so what you can see is the $31.3 million. This is a combination of Central Health operating support, patient revenue that we can get within that facility, and also the reserves that we talked about earlier this evening. And there's also a potential secured funding of $12 million to help us close the gap.
Is that 12 million from the county? Is that, Dr. Lee, what you were thinking of?
We are in open session, Vice Chair May. We will have further details in the closed session to follow.
Thanks.
Thank you, Dr. Lee. Finally, I'd like to end with, again, mental health is not inexpensive. Healthcare is not inexpensive. We want to make sure that we are good stewards of the dollar, of our taxpayer dollars, and so we are looking at John Hawkins to understand what is the return on investment upstream. How does this impact not only the healthcare of our individuals, our taxpayers, but how does this impact the emergency departments that see these individuals on a regular basis, our law enforcement partners, and other individuals that engage with people living in a mental health crisis at moments in their time. With that, I thank you for your time and am open to questions.
And there's a closed session element of this presentation as well, in which we can go into more details on the financing.
I have one quick question before I open it up, and then please feel free to let us know that we should have that in, in closed session if the question is a closed question. I want to go back to slide number 9 around the service lines of inpatient psychiatric care and psychiatric emergency. When you say youth, are you harmonizing that with the Dell Medical School's continuum of pediatric mental health that they've kind of been advocates of and created, or is that separate and apart from that, or what is the definition of youth? I know in the pediatric world, when you get to 17 or 18, then you can obviously go to an adult facility, but there is a real difference between youth and their bodies and adults, which is why we have a pediatric center, level 1 trauma center, and an adult trauma center.
We have not gotten into details of the exact age. I do think we need to lean into our partners like Dell Children's Hospital. They do already have psychiatric services in their facility. I don't think these are addition. I also understand the transition of age in between 16, 17, and 18 into 23. So we need to have those conversations. Those are not off the table yet. We need more detail and research.
And in addition to Dell Children's Medical Center, I would encourage you to, Dell Medical School has a psychiatric doctors that practice at Dell Children's Medical Center. So those are two different entities and two different places to get expertise around any feedback. Sorry, members, I'll just go around the room. I'll start with Manager Motwani.
Thank you. I think just first of all, I want to acknowledge how nimble and comprehensive y'all have been, but you, Sydney, in being able to size this up and share it back with us. So I appreciate it. And beyond that, I don't have any questions except for the ones that face us as a board collectively.
Thank you. Dr. Brinson? Manager Mercedes?
Yeah, thank you for that presentation. And I don't know if this is appropriate or not. What is the dollar amount that's asked? That I'm just seeing that operating, and there was also a handout. So for fiscal year 27, what is the proposal that you're asking for? Because
We're going to go into more detail into a pro forma in the closed session presentation. But I believe for fiscal year 2027, the ask was the 7.3 into the reserve, and then the 20 million. The 7.3 for the reserve for the Mental Health Crisis Center, because the Mental Health Crisis Center is something that still needs to be planned.
Correct.
Would have to be located, there has to be construction, so that reserve would help fund the planning, and design and, build towards filling the, ongoing, 30, where is it
Let me
on there?
build on that for a moment, if I may.
The ongoing gap in the future.
If I may, this handout you see on No Wrong Door, we had a request from the mayor's office to match a format that Integral Care produced. So this is a matched format to what Integral Care provided. I've just asked the team to provide a version I think might be used for the board, which totals these numbers at the bottom. We're going to be providing the totaled version to you now. But in the FY27 budget, the total of all of these activities in the central health budget, I believe, is $74 million. And so collectively, the FY27 proposal looks at the mental health, homelessness, addiction needs of this most vulnerable population and funds that amount to a total of $74 million, which I believe makes us, if not the largest, then very close to the largest funder of crisis care services in our community. So I think that's coming to you now. I'm not sure if that was the nature of your question, Chairman Saitiff.
okay, and I'm sorry, if I can just, so right now, so what you're saying that currently we're paying 74 slash million
No, he's saying it's in the budget.
in our
The-
current budget?
The proposed budget, The proposed budget broken out into the no wrong door components so that it's easier to see apples to apples totals to $74.7 million. You will see on the right there's a $34.4 million. We will get into it, but while I'm on it, we asked our subject matter experts who run these service lines, if you were to estimate which of these patients are directly no wrong door patients, this is their expert opinion on the ratios. So you see an estimated ratio, that's an expert opinion from our folks who do the care. But our understanding is that the population, the 100 individuals in the downtown area that are no wrong door, represents a larger population of several thousand individuals who share certain characteristics of vulnerability that Integral Care and Central Health take care of. And so the 74 million represents the total services we provide, if you will, to the part of the iceberg that may be under the water. And no wrong door, the 100 individuals at any given time might be the iceberg on top of the water. So I'm not sure if that makes sense, but 74.7 million.
So what's the denominator?
The total number of patients we serve in these,
Yes.
I think we would need to get back to you with a specific number, but we can do that.
Okay, thank you.
So, can I ask a question about this or not?
Sure, as we're kind of going, yeah, I'm right here, yeah.
Well, I can wait if you.
If you want to wait.
Sure.
Manager May?
I'll wait till close.
Dr.
I have several questions. One is about logistics. Do you envision the Mental Health Crisis Center as integrating the ER crisis unit or having an ER crisis unit expanded in the emergency room per se?
Yes.
Yes to what?
To both. So it would be, there would be expanded, So yes, there would be the expanded psychiatric emergency department in the hospital and the additional 60, not in, shoot.
If I may, I think that
Yeah,
the
there would
part
be
of
the
the
additional triage.
part of the thinking here is around timing, Dr. Martins.
About what?
Around timing. So the possibility of a partial expansion of patient psychiatric at Delsey Medical Center could be stood up sooner.
Yeah.
Yeah, potentially years sooner than a new construction of the Mental Health Crisis Center.
And also there's a role for that. I mean, say you have someone who's a suicide attempt, they've cut their neck. I mean, so my point is, I think that's important to delineate. I would run both. But, so that's that. The other thing is, if it was, and you envision it would go to Dell theoretically?
We would envision working with our Ascension colleagues.
Okay.
Central Health would pay for this bed expansion, and we would bring further details. The board would have to review and approve any proposal
Okay.
before it
And
happened.
sort of a simpleton question on funding. Have the other hospital systems been approached about assistance in funding of the running of this place, since it will be offloading a lot of patients? Is there any sort of discussion about an agreement such as that? No? Well,
there's
I would favor it should be. I mean, you're offloading a ton of patients that take up their beds in the emergency room. And they're very expensive to see and care for 12 to 24 hours while they're there.
Thank you for that.
Thank you.
Dr. Wright, any other questions? That's it. Manager Kitchen?
I'd like to see the detailed numbers, which I think we're gonna get, and then, I'd just like to see them.
Okay. That's coming. Manager Jefferson? Okay.
Well, when you did your research at Salt Lake, did we only look at one system? Let me just kind of explain what my concern is. Mental health is definitely a part of overall health and is very necessary. I believe in the past, I want to say about 20 years ago, Portland, Oregon had a problem where their mental health services were so good that people were actually moving there to get them, folks who are in their early 20s or whatever, no jobs or whatever, moving there to get them. So instead of kind of taking care, the taxpayers taking care of their own, they were taking their allure, they were attracting. So how do you solve for that? And then also, we don't want to create a system where folks who might be able to get some form of coverage through their, parents up to age 26 or whatever, where they're just not, oh, you know what, you're going to get a better deal, and just, and I don't want to sound harsh, but it's an offloading problem that I don't think we want to invite.
I'm smiling because if we created such a great mental health system and people were traveling here, I would be over the moon. So I'm smiling because of that. In other states that we looked at, which there have been many, and this is not just a new thing that we've started looking at in the past 8 months. Travis County and the city have looked at multiple facilities across Arizona, Nashville, Miami, California. We have looked at every single one. Salt Lake is different because it is exactly a no wrong door. And now I'm not saying let's open the door for every single individual. Individuals that have the opportunity to pay for services can go to a place like an inpatient, private inpatient mental health facility. The population that we are going to serve doesn't have that opportunity. Right now they are suffering on the streets because they don't know where to go, or they're going into our emergency departments and they're staying there for hours, potentially days, because there's not another bed that they can get into. And so by creating a mental health crisis center, we're creating that space. And when an individual gets care more quickly and effectively, their symptoms decrease more efficiently, and then they are then back on their feet and back to being a part of the society that they were once part of. So if we could create a place where everybody would come to, I would love that. But I know, I understand the hesitation.
And in the next presentation in closed session, when we go through the pro formas, there is anticipated patient revenue that would sustain, and other funding sources that would sustain the operations of the mental health crisis center, but we need to be in closed session to go into more detail about that right now. But I think that will answer a lot of your questions about how the people with different funding streams might utilize these services so that it's mutually supportive. And we also looked at the models in Fort Worth, Houston, the Permian Basin, and Lubbock, and have taken some of the elements of those models that are Texas models that are, that our peers are operating.
Manager Kitchen, you had a follow-up
Yeah,
question?
I have a question about the handout about the no wrong door funding realignment opportunities. Do I ask that now, or is that in closed?
Should we wait for close, because that's where the pro forma
Perhaps
is gonna
close
be.
would be
Okay.
a better
All
prideful
right,
answer.
then I
yeah.
reserve my questions for that.
Members, any other questions? I know one comment I want to make just, or a request of y'all. We have talked with Dr. Lee and we haven't sent anything out to y'all, but if you all have interest in visiting the Huntsman Center, we can try to schedule that. So if you would express your interest to Bedla and her team, we can try to figure that out. I don't know how quickly we can do that before the budget, or whether it even matters before the budget vote, but I think it's always important to go see what you described. I'm a big fan of going and talking to the people that actually started it and are doing it. And so if you all are interested, please let Bedla know. Let's discuss that in closed. Members, any other questions? If not, Sydney, Monica, thank you so much. And I'm gonna move us to the
They're coming back for closed, right?
Yes, yes. I am announcing, thank y'all. I'm announcing that the board is convening in closed session to discuss agenda item 10 under Texas Government Code 551.071, consultation with attorney, and Texas Health and Safety Code 161.032B2, records and proceedings confidential. Agenda item 11 under Texas Government Code 551.071, consultation with attorney, and Texas Government Code 551.072, deliberation regarding real property. Agenda items 12 and 13 under Texas Government Code 551.071, consultation with attorney, and agenda item 14 under Texas Government Code 551.071, consultation with attorney, and Texas Government Code 551.074, personnel matters. And the time is now, well, it's August 26, 2026 at 9:27 p.m. Thank you. Oh, that's right. Sorry. Agenda item 10 is discuss and take appropriate action regarding a compliance update by the Chief Compliance Officer. Receive a report from the Chief Compliance Officer regarding a pending investigation. Item 11 is receive, discuss, and take appropriate action regarding an update on expansion of the mental health continuum of care and associated partnerships. Item 12 is receive and discuss an overview of regulatory issues impacting the central health system. Item 13 is to receive and discuss a briefing regarding Birch et al. Versus Travis County Healthcare District doing business as Central Health and Dr. Patrick Lee, cause number D1GN17005824 in the 345th District Court of Travis County, and services provided by faculty and residents of the University of Texas at Austin Dell Medical School in support of Central Health's mission. And item 14, deliberation and possible action on the appointment, employment, evaluation, reassignment, duties, discipline, or dismissal of one or more Central Health employees. So now and again, the time is 9:28 p.m. on August 26, 2026. Yeah, we're gonna just do this in order, so we'll do the investigation first. Are we ready for the closed session? Dude, nothing has to be recorded, right? Not this one? Okay, so. I think we're gonna ask all of the staff to leave the room. And that includes you, Dr. Lee, as well. I think we're just gonna have the board members in the room with the attorneys right now. Oh, David, do I need to announce the date and do all that in closed session?
We'll have you do that when you do the next time, because it was attorney-client, we're not recording anymore. So when we come back, when y'all are done.
Okay, so I don't have to do all the Yeah, I'm ready. Today is August 26, 2026 at 11:13 p.m. and we're entering open session. Managers, our next regular board meeting is tentatively scheduled for Monday, August 31st, 2026 at 4 p.m. at the Central Health Headquarters, 1111 East Cesar Chavez, Austin, Texas, 78702. And at this time, am ready to accept the motion for adjournment. And do I have a motion and a second to adjourn. All those in favor, please raise your hands. So the motion passes unanimously. The time is now 11:13 p.m. on August 26, 2026.